broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome back to the PM session. My name is Nicolas Rondeau-Lapierre, and I will be your virtual coordinator for the PM session. We're just going to have to wait a little bit more. I guess everyone's eating lunch, just finishing their lice bites. So we'll wait a little 30 seconds before we go through, again, a technical aspect of the presentation and then jump right into the session. You do have the program in the handout section if ever you wanted to know a bit of the program for the PM session. You just have to download the document in the handout section. All right, I think we are good to go for the PM session, so let's jump right into it. We'll go over some of the technical aspects. Again, very similar to the AM, so nothing should be new for you guys. Familiarize yourself with the control panel, ensure your audio is working. If it's not working, there's an option to call in at any time. If you have any question or technical difficulties, please click the question mark button and send us your requests, and we'll get you back online or correct the technical issue as soon as possible. Question period, we encourage attendees to ask as many questions as they feel. So please send your question during the presentation, so that way in the Q&A part, we're not kind of waiting for the question. So go right ahead, and then the moderator will speak with the speaker to answer your questions. There will be obviously a Q&A period after each presentation and a break before the second and final presentation. So with no further ado, let's introduce again our moderators for today, Dr. Andrew Ross and Dr. Jean-Luc Urbain, and I will be in the background coordinating everything. So enjoy the PM session, everyone. Cheers. Dr. Ross, your audio is not working.
Thank you for that, Nicola. Talking into the nothing. I say thanks, Nicola. We will move forward. The first presentation this afternoon, well, just to again reiterate a couple things. First of all, as Nicola says, try to, if you're interested in asking questions, if you can submit those when they're on your mind, both during the presentation, that's great. It helps for organizational flow, and as well, you don't forget it. And if there's any duplicates, we can generally get those sorted together. Second thing is accreditation. There will be an evaluation form that's really important for this, so we will remind you again, but that'll be coming in your email. So if you don't see it, it may get bumped to your junk folder or your clutter folder. So keep an eye on that, because that's both for accreditation and for feedback to us. We said the thank yous to everybody earlier today, so I think we'll move right on. The first lecture this afternoon is by Dr. Eric Turcotte, who's a very good friend of mine. I've known him for a long, long time. When I looked at his bio and it talks about him being in clinical practice for over 20 years, it certainly talks about how gray my hair is, or how much of it's falling out, because it seems like just yesterday that I met him when I went up to the University of Sherbrooke and the SHUS for PET sabbatical back a long, long time ago. So Dr. Turcotte is a very, very esteemed fellow in the world of clinical and investigational PET. For those who, I think most people on the call today will know that, the University of Sherbrooke is a Canadian center of excellence for PET technology, and has been for decades. They have a long history, and I think Eric will get into that a little bit in his conversation today. They have done a tremendous amount of groundbreaking research over the years, and I think looking at some of the things that Eric has under his CV at this point in terms of taking radio tracers from preclinical into the clinical world, and as well getting both CTAs and NOCs, getting drugs licensed for human use, particularly the PET agents, is truly a significant feather and important for clinical service in his province and also in this country in general. He is currently the clinical head of research at the Sherbrooke Molecular Imaging Center, and he's led over 30 clinical research studies. He's also been involved in multiple other areas, including the Royal College examination process as the co-chair for that for a number of years. He did his training in Sherbrooke in medicine and nuclear medicine, and then he did a postdoctoral fellowship in PET at the University of Washington in Seattle. And as said, he's been a significant clinical and research person for the last number of decades in Sherbrooke. So without further ado, I think I will let Eric take over the show and talk to us about the evolution of positron emission tomography.
Thank you, Andrew. Here we go. So everybody's seeing my screen?
It's all good, Eric.
It's all good. Great. So thank you very much for the invitation. I hope that everybody had a great lunch and took also advantage of that great weather outside. That's very fantastic to have that weather during that time of the year. So for the one that knows me, I'm doing PET since a long time, since I graduated in 2001. And since that time, I did PET. I've been doing PET full time since that time. So I saw positron emission tomography evolving so much over time, an evolution in terms of medical indication on scanner design, as well as new radio tracer. So I would like to share with you my vision of what's changed from the beginning of PET in Canada, especially in Sherbrooke in Quebec, and to see what is the future of that technology, what is my vision of that over time. So we'll start with some statistic, but just before that, I need to declare that I have no conflict of interest, so I swear. So let's start with some statistic. You know that there is about 57 PET scans available in Canada. 75% of them are installed in Ontario and also in Quebec in a ratio of 40% for Quebec and 35% in Ontario. So just two provinces is more than 75% of the overall PET scanners on Canadian ground. In Quebec, there is 27 scanners in 20 different institutions. If we want to split them, there is 22 scanners in 17 public hospitals. So you understand there that some hospitals have more than one scanner. 2 scanners are in research, research scanners, and 3 are private scanners. So if we compare the number of available scanners to million in population, in Quebec, that refers to 2.7 public scanners per million people. That's comparable to France and Belgium, but that's a way behind US, which is at the double of PET CT scanners per million. So they have a lot of money to buy those scanners. So, but Quebec is doing well. But if you look at Canada, including Quebec and Ontario, which have more scanner, we have on Canadian ground about 1.5 PET CT scanners per million population. And that's bad because it's comparable to Czech Republic and Slovenia, and I have nothing bad with those countries. But Canada is certainly not a leader in PET CT. In 2019, the Quebec government decided to replace 10 scanners. So 8 of those scanners were quite old scanners, between 13 and 17 years old scanners. But 2 of them were installed in new institutions, one in Val d'Or and one in Sacré-Cœur. All of those scanners that were bought by the Quebec government are now SIPM scanners. called the digital scanners. I will talk a little bit later about that kind of technology. And many centers opt for the largest possible axial field of view of 25 centimeters compared to the other kind of scanners that were more like 19 or 20 centimeters. On the CT side, everybody opted for a 64 slices, and that kind of scanner is now the base kind of scanner that Quebec will buy in the future. So, oops, sorry. So many scanners are already installed in Quebec, many still under installation. And now we are starting a new process to update 7 other scanners in 2021, with again a possibility of adding scanners to new sites. Overall, Quebec is updating 70% of the public equipment park in PET-CT around Quebec. So how many exams we do now with these scanners? It's 68,000 exams that were made in 2018, 2019. And compared to the overall Canadian number of exams, which is 130,000 exams, Quebec's performed 52% of the overall global PET-CT exams. Compared to the, by thousand of population, Canada do about 3.4 PET-CT per 1,000 people, and that's comparable to Australia. Quebec, we do 8 exams per 1,000 people, and that puts us comparable again to France and Belgium, so European country. And Quebec is doing very well because we do a bit more PET-CT per 1,000 population than US. 1 exam per 1,000, 7 exams in the US compared to 8 exams per 1,000 population in Canada. So with the population growth, the new indication, the new radio tracer, we expect to go over 75,000 scans per year very soon in Quebec. And we'll look at about that more closely based on Sherbrooke annual data. So this is a graph showing the number of PET-CT scans performed in Sherbrooke for the last 6 years. And it's very easy to see that there's a trend, so an upslope. We are doing about 10% increase in PET-CT every year. So it's about 40% more PET-CT in 5 years. So that explains a bit why we do more and more in Sherbrooke. But the problem is, even if we do more and more exams a year, the waiting list is just moving the opposite. So I showed you here the waiting list from 2015 up to now. And it's very easy to see that there is big bump. So one of the first bump we faced was in 2017, when the increase in PET-CT referrals were just getting up and up every week. So at that time, the institution decided to put more technologists to open extended hours, open during the weekend, to bring the waiting list down to something more reasonable. But since then, we still have an upslope in the waiting list. We are getting into the same situation, even if we do more PET-CT. So you offer more, you receive more, you do more, and it's just turning into a cycle. And just to put that here into your attention, this is the summer bump that I name it like this, because that's the bump we're facing every year when the staff is going into vacation. So we are now, like today, scanning during the weekend to try to control that waiting list. So if we look more closely on where those patients are getting from, to show you what kind of PET-CT we are doing. Is it a patient hospitalized or another patient? So we're still doing much more outpatient than hospitalized patient, and the trend is increasing over time. So we receive more referrals from people from the hospital and around the hospital. And one thing that is very interesting is to see the increase for referrals from the specialist inside Sherbrooke, the Sherbrooke Hospital, which is a bit increasing, and especially those exams are requested by the intensive care unit. So they are requesting PET for sustained bacteremia to find infectious foci and things more related to internal medicine and not really cancer-based use of PET. And the other thing that is very interesting is to see that physicians that are outside our hospital are not requesting PET or very small number of PET when their patients are hospitalized outside Sherbrooke. So in other words, specialists having not direct access to a PET CT on site will not ask for a PET CT if their patients are hospitalized. So that's something to take into account and maybe to try to figure out what's going on, what is the main explanation why these patients are not, don't have benefits from PET, and trying to increase a little bit the referral from the hospitalized patient. And the other thing that is very interesting is to see which kind of exams we are doing more and which kind of exams we are doing a bit less. So you know that Sherbrooke, since 2016, we are offering octreotide. At the beginning, when I was talking with my institution, the only question they had for me is, how many octreotide you think you will do a year? So my first answer was based just on Sherbrooke experience. And my answer was, no more than 50 a year. So I was wrong, because we did for the first year 500 octreotide scan. The year after, 600. The year after, almost 800, and it's just keep increasing. So new tracers are very, very important in the development of PET CT. And the octreotide is just one example. So imagine the example with PSMA, when PSMA will be available in many centers. It will just be a very upslope of exams that will maybe overload the system. The other kind of exams we are receiving more is for inflammation. So sustained bacteremia, cardiac infection, finding foci of sustained infection, that's an increased demand on our PET CT. Radiotherapy training, a bit decreasing, and brain imaging, a little bit decreasing. And I just want to put the emphasis that this is the Sherbrooke experience, and other centers in Quebec may have an increase in brain imaging. But here in Sherbrooke, we are seeing a little bit of decrease in that. Breakdown in the medical specialty, hemato-oncology and pneumologist still the one prescribing the most PET CT. And the third one in Sherbrooke is now internal medicine. So 20 years ago, I wasn't thinking about internal medicine requesting for PET, but now it's a reality. There is indication, and internal medicine physicians are requesting. And another thing that is very important to know in Quebec, a lot of medical specialists may ask for PET CT. You may have a request from the family physician, any kind of specialist, even a nurse practitioner are allowed to prescribe a PET CT. This is very different from other provinces. A breakdown by cancer type. Lung and lymphoma occupy 50% of the time of our scanners. And with the advent of new tracer, we are seeing a bit more of breast indication with the estrogen analog use, and also with the prostate cancer with the PSMA, an increase in neuroendocrine with octreotide. And here with the skin cancer, the melanoma, I just want to put an emphasis on a small warning with that kind of therapy that are used for melanoma that are named the checkpoint inhibitors. So those checkpoint inhibitors can create a very special reaction that maybe some of you are used or maybe not, which is called the pseudo progression. So that kind of medication activate the immune system, and the immune system may invade the tumor, make it grow. It may look also more intense with FDG. And this is just a normal reaction induced by the medication, which is called the pseudo progression. Even a new lesion is not a progressive disease. It's just maybe just pseudo progression. And I put here just an example for you. This is the first scan before starting the immune checkpoint inhibitor, where you see small metastasis in the pelvis. 3 months after starting the medication, you're seeing more lesions, the one that were already visible grow, and it looks like a progressive disease. No, it's not a progressive disease, because 6 months later, everything disappears. So that's something that you have to take into account. It appears in about 50% of time when people are taking anti-CTLA-4 medication like ipilimumab. And it's more often also with melanoma. And we are seeing very, very strange thing with that medication. Like here, an example of a woman having a bladder cancer that was placed under immune therapy. And after 3 months of therapy, she developed a very intense lymph node in the axillary, in a very intense reaction over the breast implants. Look, it looks like the immune system is rejecting the breast implants and creating inflammatory lymph node. And it looks very impressive, but that's the kind of strange things that these medications may do. And we have to be aware of that and to try to find a way to avoid the false positivity of tumor progression under that kind of therapy. So that's a very important field to understand and to keep a hand on, because so many cancers are now treated with immune checkpoint inhibitors that if PET is not able to figure out which one progress and which one is doing better, we may lose some field, very important field in PET. So we have to work on that and to find a way to understand that reaction. Many tracers are now used in Quebec. Many of them are approved. And many centers are also relying on CTA, so on clinical trial application with Health Canada, to use non-approved radio tracer for their population. So in Quebec, and they are not all used across Quebec, but you have access to FDG, sodium fluoride in many centers, octreotide in many centers now, rubidium chloride mainly in Heart Institute, estrogen receptor imaging here in Sherbrooke, PSMA under CTA in a few centers in Quebec, choline, ammonia, fluorbetabine. So these are all radio tracers that can be used in different centers to do clinical assessment, so real clinical report and diagnosis. Here's an example here in Sherbrooke, just to illustrate the role of estrogen imaging, because maybe some of you already know that those tracers are allowed now in the US. The FES is now approved. We do MFES in Sherbrooke, and in this example, there is absolutely no lesion visible on FDG, and on the MFES, that patient was perimetastatic. Everywhere, even in the inguinal region, there were metastases right there. So by knowing now that we have a tracer that showed a disease compared to FDG, it's possible to treat that patient over time and to see the reaction or the response inside the body. So that patient was placed under estrogen receptor blockage, and we see over time at 6, 12, and 18 months, a down regulation of the estrogen receptor, showing a response for the patient. For the few of them that's still doing octreoscan, I would like to give you some chill. and to convince you to maybe try to offer octreotate instead of octreoscan for your patient. That in this example, you have a lady that was scanned in August 29. She was also scanned in December 5th. Both scans were read as negative, but that lady was so symptomatic that the physician referred her for an octreotate scan. Look at the scan, and I'm pretty sure that you will have chills. So it was a totally misdiagnosed multi-metastatic neuroendocrine tumor missed with octreoscan. And that's the regular presentation I'm saying. It's not rare for me to see someone with a negative octreoscan with a multiple disease octreotate. So that's my point. And PSMA will do exactly the same thing with the bone scan. Here an example from Sherbrooke. You see the bone scan. There's, of course, many visible metastases. That this is not a normal bone scan. But when you look at the PSMA, in Sherbrooke it's PSMA 617, many lesions were missed by the bone scan. And what is beautiful with PSMA, you also see the soft tissue metastasis. FDG versus PSMA 617, almost the same thing. You look at the bone marrow, it's a little bit heterogeneous. It looks like a mini bone metastasis. We did the PSMA 617. Of course, there's many bone metastasis, but much more than that. And you see on the CT scan all the osteoblastic lesions, which were a bit visible on FDG, but so much visible on PSMA. And because PSMA will put a huge load on the system, and of course because PSMA needs gallium-68, in Sherbrooke we decided to quit the gallium-68 generator and to move to the direct production of gallium-68 by cyclotron. And what's the idea behind? The idea is quite simple. With a generator, you may offer about 2 to 4 scans per elution. So in the context of prostate cancer, it looks like a lottery. So you have to get a ticket, and the good ticket to reach for a scan. So you need absolutely to rely to some things different from the gallium-68 generator. So in Sherbrooke, we are able to produce daily 22 gigabecquerel of gallium-68. And by the end of synthesis, we're still having about 300, 324 millicuries of final radiotracer to inject to patients. So in Sherbrooke, we are injecting gallium-68 in amount of 10 millicuries. So I don't think there is no other center in the world that are injecting 10 millicuries per patient for doing a gallium-68 scan. And look how much beautiful those scans are. So it's possible for us to perform 12 scans per day, 5 days a week. So I think that we will be able to perform a huge load of gallium-68 PSMA in the future. So what are the trends in Quebec for position emission tomography? So the trends are to provide faster examination with lower radiation dose, higher quality imaging, and by the end, because these are publicly funded, we have to try to save money by being more efficient. And one thing is very clear in Quebec, PET contributes to the growth in healthcare costs, but because it reduces further testing, it decreases long-term care costs. So by this sentence, we understand that even if PET increase the cost of a medical event, overall, you will decrease the long-term cost of these patients. And how? We are planning to produce more PET scans per day. But first, by updating to faster scanners, and that's what the Quebec government is doing right now by updating 70% of the equipment between 2019 and 2022. Have more scanner per site. If not all, university hospitals have more than one scanner now. Have more sites with a scanner, and you all certainly heard that they install a PET scan in Val d'Or. Val d'Or is about 550 kilometers away from Montreal. This is the farthest PET scan installed in Quebec. So Francois, look at that guy, he looks proud because he was able to bring a scanner so far in the province. So the idea in Quebec is to have access also in rural area. So that explains why Val d'Or, Chicoutimi, or even Rimouski have their own PET CT. And our biggest challenge in Quebec overall now is to have enough technologists. We would like to have a ratio of 4 technologists per scanner. So for us now, the baseline for a faster scanner in Quebec is based on the SIPM detector. So those SIPM detectors, we call them digital, but they are not purely digital because you have analog SIPM, you have real digital SIPM, but the one currently on the market, except one manufacturer, are analog SIPM. But just after the SIPM, you have an analog to digital converter that converts the analog signal to digital, and they call that a digital scanner. This is not the real the real name, but it makes sense overall. But by the end, that small difference between the digital or the analog to digital is not so important, because that technology, the big point is that they have a very better temporal resolution for the time of flight compared to any PM tube available on the market. So those detectors can reach a time of flight between 200 to 400 picoseconds. Overall, you have a better count rate or an effective count rate, a better signal, you're able to see smaller lesions. And the other baseline for a faster scanner in Quebec is based on the field of view, so the maximal field of view. And now I think that there is a battle from manufacturer of which one will have the longest actual field of view, from 16 centimeters up to 194 centimeters, so the whole body scan. There is a bunch of available scanners in between. And which one to opt? The answer is quite easy, the one that your hospital can afford. There is no answer different than that. And many centers in Quebec were able to afford a 20 centimeters ring for their scanner. What are the main advantage of that? We're able to scan 50% faster than our previous system. There's many opportunity that the hospital may have. You may project maybe to use a lower FDG dose and scan for the same time and save in the FDG money. You may also use the same FDG dose and scan 50% faster. That's what we choose here in Sherbrooke. But the main limiting factor that we have is the number of technologists. At a certain point, you have a scanner very fast, but you don't have the technologists faster than the camera. So if you're able to, let's say, to scan a patient every 5 minutes because your scanner is so fast, try to find a technologist that will be able to feed your scanner every 5 minutes. You will have a hard time. So we have to take that into account when we choose the actual field of view. So it's good to have a 25 centimeter, but we need to have the team to feed that scanner. And some friends already try also to do a mixture between scanning time and save it in FDG dose. And it's possible to save a lot of money in FDG a week by doing more patients for the same FDG amount. Here, an example of a 114 kilogram patient on our old PM tube system. That scan took 37 minutes. So we scan at 2 minutes for the upper part, and we drop the time to 1 minute for the legs. Look at the same patient, the same dose. We just scan it a few minutes later with the digital scanner. So that's very, very different. So we are not in the same ball game. And that scan took 50% less time than the first one. So that gives the opportunity to do real whole body scan without or with minor impact on the overall schedule. For example, here, a lady of 95 kilograms, 168 centimeters, that was injected with 10 millicuries. That scan on our whole system with PM tube took 29 minutes with 2.5 minutes per bed position. And now, with the new scanner, we did with the third of time, we achieve a better imaging quality, so better diagnostic possibility with this scanner. And even in, I want to show you that image because it was the first time in my life that I was able to see. That was in a case of pacemaker infection. And if you look closely, you will see that there is a line coming from the pacemaker down to the heart. If we look on the fusion images, so the line is right there. If you look at the fusion images, it's a wire infection. So it's the first time in 20 years that I'm seeing an images of wire infection. So I think that those kind of SIPM scanner should be prioritized over any other kind of available scanner, especially the PM tube scanner. And those scanner should replace any older scanner. So in conclusion, so Quebec is speeding up its capacity to provide PET exam by updating many of their equipment park, 70% of the equipment park, and also by adding scanner in rural and into urban zone. Why? I showed you the demand is growing and it's growing every year. And the waiting list in my centers and maybe in many centers in Quebec is just getting longer. There is new tracer that are just next door, the PSMA. The day PSMA enter your center, be ready to overload your system because prostate cancer is so, there is so many prostate cancer that the indication will follow. And PET also in Quebec and also in other part of the country are getting more necessary to take clinical decision. The resident, the trainees are trained with PET. So the day they become a specialist, they want access to PET. So we need to be able to provide them the exam they need also on time. So the biggest problem we'll have to face is just about manpower, which is not readily available. We need more technologists, we need more specialists to read these exams. So this is where we are now in Quebec. Thank you.
Thank you, Eric. That's a great review, and it's always amazing to see what's going on both in your center and La Belle Provence. You've certainly been leaders in the country, getting us to where we are now. I think the rest of Canada, as they call it, is slowly catching up, and we're always really happy to hear what's going on in terms of the potential for the future. We here in Halifax just got our new digital scanner in the last 6 months, and it's certainly revolutionized our practice here in terms of the imaging and the throughput and all those things. So, and as we heard through lunch from some of the vendors, that there's, I think, even more coming. It's going to be even more exciting. Eric, we've got a couple of questions that have come in while you've been talking. The first one from Dr. Evely out in Edmonton. He's asking, how quickly can you get inpatients onto the scanner in Sherbrooke? How do you fit them into your workflow?
Currently, the workflow is we're trying to figure out how we can scan one patient every 10 minutes. So that's the pace with the number of referrals and the waiting list. If we want to beat the waiting list, we need to provide a scan each 10 minutes.
Is that per scanner, Eric? Is that per one scanner you're talking?
Per one scanner. So currently a day in Sherbrooke, by 8 working hours, we do between 32 34 scans. So when we do extended hours, so it's more scan, and like today during weekend, it's 30 more scans. So we are in the process to ramp up maybe to 200 scans a week.
What's your dose you're using for those patients at this point? For FDG, for instance?
Because we are our own FDG producer, it's between 5 to 10 millicuries per patient.
Weight dependent, presumably?
Yeah.
So with that kind of throughput, you basically, do you prioritize your inpatients and basically get them kind of within a day of a receipt of the requisition or the
We receive a requisition, and every physician will look at the referral. So we look the indication and we recode the exams into priority. So it's possible to provide a PET scan in less than 24 hours if the indication is there. So we follow what the Quebec government asks us to follow as a regular waiting time.
Cool. Another question, not so much about the future, but a practical clinical question for you, asked by Dr. Cote-Martin. What is your approach for patients referred for pulmonary carcinoid tumors, knowing that there may be a false negative with the gallium dotatate? Do you prefer Octria scan in those patients?
Very good question. Okay, so it will be more experience-based kind of answer. Those kind of cancer, so the pulmonary carcinoid are not working well with octreotate. Okay, and it already happens quite a times that those tumors were visible on octreoscan and were not visible on octreotate. So the way I'm explaining that, it's maybe that there's, when you look at the SSTR overexpression that are targeted by octreotate compared to octreoscan, octreotate is 245, SSTR 245, and octreoscan you add SSTR 3. So I think that the pulmonary carcinoid overexpress more SSTR 3, which is a gap inside the octreotate scan. So I prefer, I would try them because sometimes it works, but if it's not working, I'm stuck that my PET will not help. So that's a very good question, and there is not a very good answer.
Thank you. And the last question for us for the day is, how are you managing the number of cases versus physician reading to keep your standards high and not kill people? Doctors, that is.
Okay, first I'm still alive, so that's a good point. Okay, no, that's a main problem, and the problem we're having right now, it's more a problem related also with COVID-19. In Sherbrooke, for the one that did their training in Sherbrooke, you know that we are inside reading rooms. So we are 4 or 5 physicians in the reading room talking all together. So it was our model till last winter when the COVID-19 arrived. So now we are putting the physician back in their office, delocalize the reading. We have 3 different centers here in Sherbrooke, so there's many possibilities to read. So we are dispatching more and more exams to other physicians, and I would like to reach a ratio of no more than 15 PET scans per physician a day.
That's a safe limit, you figure. That's a safe number.
Yeah.
Well, Dr. Turcotte, Eric, I would love to say thank you on behalf of the Canadian Association of Nuclear Medicine. I wish you all the best. Enjoy the great weather that we're having, at least in the eastern part of Canada at this point. And I will now hand over to my colleague, Dr. Urbain, to take it from here. Thanks again, Eric.
Always a pleasure.
Thank you very much, Andrew. Thank you very much, Eric. It's my pleasure to introduce to you Dr. Shireen Isaac. Shireen and I have known each other for quite a few years from my time in Ontario. We have stayed in touch. My approach in medicine is that patient management come first. Which type of tool do we have to help out those on the front line of treatment, diagnosis and treatment, like Dr. Isaac when he sees a patient in his office. We had multiple conversations over the past few years in terms of how to proceed. Dr. Isaac is professor of medicine and oncology at UHN. When I have a question about neuroendocrine tumor and eventually to approach it, I call him. Is to me the brightest mind in neuroendocrine tumor in North America. PRRT is upon us. We use it. We promote it. However, and it has been my experience, and Shireen will share his experience, not necessarily the magic bullet that patients are expecting. So we definitely have to be very cautious, attentive, and see which tool ultimately those who are in the front line diagnosing and treating these patients are using. So it's really my pleasure and honor to have Shireen explaining to you the way he deals with his patient and treat his patient. Shireen, thank you very much for taking your time on Saturday afternoon. The floor is yours.
Thank you so much, John. Look, I appreciate the invitation. I'm not sure if the audience will agree with you about me being the brightest, but I will do my best to show where our weaknesses are. So I thank you again, and I appreciate the opportunity. My disclosures are shown here on this slide. And I want to really take you through the entire spectrum of neuroendocrine tumors. And I want to be as open as I can be about the diagnostic dilemmas and why therapies aren't always quite as straightforward as we would like them to be. And hence why, as Jean-Luc mentioned, it's absolutely necessary to have a team with complementary expertise that are able to talk to each other on an ongoing basis in managing these cases. I want to show you this slide because, as you all know, recently peptide radioreceptor therapy was approved in the United States and more recently in Canada, including most provinces now. And you will see in the indication that people refer to so-called mid-gut neuroendocrine tumors as being where PRT is indicated. Now, I'm going to tell you a little bit that this is probably an oversimplification, and hopefully in the next few slides you'll understand why I say that. I want to emphasize that classically the entire GI tract is divided into the foregut, which includes these organs. The midgut begins from the distal duodenum all the way down to the transverse colon, the hindgut being down here. Now, this is the so-called anatomical location, and this really represents medicine as we understood it in the last century. What we do understand now is that we have to look at evidence. And in fact, neuroendocrine tumors, as shown even going back to a decade ago, the largest numbers of cases that we're seeing and that are problematic are not just small bowel, as shown here, but you'll see the largest increases are actually in the green here, rectal neuroendocrine tumor. That's hindgut. And in fact, the largest of all is lung neuroendocrine tumors, which are very problematic. And I will come back to the question that was asked by the audience earlier about imaging for lung neuroendocrine tumors. But this slide alone just shows you that there's a whole spectrum of neuroendocrine tumors throughout the body anatomically that go beyond so-called mid-gut. And I want to take you back to embryology so that people really understand what we're talking about really when we talk about neuroendocrine are diseases and tumors that arise from modified neurons and neuroendocrine epithelium. The reason why I say this is it's absolutely critical to appreciate what markers can be used on biopsies to help establish where the primary tumor is and how this maintains fidelity throughout the developing organs and ultimately the neoplasms that arise from these neuroendocrine cells. And it's not just GI and it's not just lung, it actually includes the pancreas, even pituitary, in some cases even parathyroid, and the C-cell medullary thyroid carcinomas. These are neuroendocrine. And up here you will see a very important component that often is overlooked are paragangliomas and pheochromocytomas. I'm going to come back to that a little bit later because you will see a large body of literature in the past where people were treated with ultra scanning and maybe even thinking that these are in fact neuroendocrine tumors, when in fact they are representing the other end of a spectrum. And this is absolutely crucial in appreciating because there are many other clinical implications. I want to emphasize this is quite separate from steroid-producing cells, which include the adrenocortical cells and the thyroid follicular-derived carcinomas, which are really separate from these and tend not to express somatostatin receptors and other markers. So the embryology is absolutely crucial. The second thing that I want to emphasize is that what we've come to appreciate, certainly over the last 20 years, is that how the neuroendocrine cancers behave is not dependent on their anatomically, but rather more on the grading. And that indeed a WHO defined grade 1 patient will do much better in terms of survival compared to the grade 2 or grade 3, which can be very problematic. Now, I want to emphasize, because of the importance of grading, it's absolutely crucial to know how this grading was obtained. Was it on a biopsy? What type of biopsy? Was it a core? How much tissue? How many cells? Because this will risk stratify the patient, and it's absolutely crucial to appreciate exactly where you're at. Now you can say, well, what does that mean to me? Well, in many protocols, including the NETTER-1 studies, they in fact included lower grade tumors, patients where the grading was more in this range rather than this range. These are the more problematic cases. And it's important for us to stay honest about this because this is where the biggest need actually is. The second thing that I want to emphasize is beyond grading, it happens to be also the cell of origin, not the anatomical origin, but the cell of origin. And we recognize that neuroendocrine cells, for example, in the GI tract, including gastrin-producing, glucagon-producing, insulin-secretin, they're all listed here, each with a different syndrome, which, by the way, can be aggravated during disease progression and even with therapy, where I've seen, for instance, PRRT unmask and worsen these symptoms temporarily. And it's absolutely crucial you be aware of this because otherwise you can get into trouble. There are also other cells that we don't know exactly why their hormones don't have a clinical syndrome, but we're beginning to appreciate more. For example, CCK will affect gallbladder contractility and result in a lot of gallbladder disease and stones in many of these patients. But I want to again emphasize that when you rely on histology, sometimes it's difficult, especially in neuroendocrine tumors, that the primary may not be obvious and malignancy may not be obvious either. So even though the grading that I mentioned provides some support on the biology of a disease, often we really don't know how that disease is going to progress. And this is a very important consideration when it comes to nuclear medicine, because knowing when you're going to apply the different imaging modalities and when you're going to apply the different peptide radioreceptor therapies. And I want to emphasize that this is a growing area, and this is the reason why it's not one size fits all. Here's a slide, for example, it just shows you about the importance of cell type. These are all rectal neuroendocrine tumors. They're all stratified by grading and by size and by lymph nodes. And the one take-home message that you're going to see in the bottom right-hand corner here is that matched for all these other confounders, the patients that happen to have the L cell type of rectal neuroendocrine tumor do far better in terms of survival compared to those with none L cell type. Same tumor, same grade, same stage, but different cell type of the rectal neuroendocrine tumors. So the cell type is absolutely crucial. And you're going to be asking yourselves these questions as we go through PRT, because one of the things you're going to ask is, what's the natural history? What's the survival of this patient? Where are they in their journey where my management is going to hopefully make a difference? So in trying to look at therapies, again, for those of you who are going to be probably involved in PRT, you really have to also be aware of what the other options are and how we generally treat these patients. So of course, surgery is always ideal when it's possible, but it's rarely curative because, as you know, many patients are identified late during the disease. We try to do debulking as much as we can with RFA, embolization, blend or chemo. But importantly, we also try to introduce radiation when necessary, and that can be external beamed for bone metastases that are symptomatic. We can use a number of modalities for imaging, which I'm going to go through, but I'm going to begin with the medical options. And it's important to appreciate these medical options, not that they are instead of, but rather how they will work in the armamentarium that includes PRT. So many of you are aware of somatostatin analogs, and we use somatostatin analogs all the time. They include octreotide and lanreotide. But as Eric mentioned earlier, the analogs that are available right now mainly target SSTR2 and to a lesser extent SSTR5. We also use that same backbone as a chelating agent for the imaging, which means that we primarily detect those receptors that happen to be expressed by the tumor. There are other analogs that are being developed, and one of them that happens to be available in Canada is called pasireotide, which is an analog that targets all somatostatin receptors, but that also makes it less specific. There are also other compounds that I'm going to show here, other classes of therapies, which I will explain in a second. But I've summarized them really for your perusal here in this slide, just to show you the major trials that have been performed. And these include here Clarinet, where lanreotide was one of the somatostatin analogs in a different type of tumors where it was included. Everolimus, which is an mTOR inhibitor, and that was shown in the RADIANT-4 studies to be very useful in low to mid-grade neuroendocrine tumors of this type. And of course, NETTER-1, which I'm sure all of you know by now, where lutetium-177 was tested as the PRT for treating mid-gut small bowel neuroendocrine tumors. I wanted to show you this slide just to get an appreciation of what happens when patients have been heavily pretreated. These are patients with pancreatic neuroendocrine tumors, and these are the progression-free survival curves. And you'll see that everolimus has an advantage here when compared with sunitinib, for example, another tyrosine kinase inhibitor. This slide shows you actually that the disease is fairly aggressive and it does progress, and when it starts to go fast, it really does go fast. These are not always indolent type of tumors. And indeed, the survival curves are shown here. You'll see that 50% of patients can be dead in 1 year. So this is not a benign disease. This is not a cancer-like disease. This is a bona fide cancer. And here again, you can see that the everolimus has an advantage. And for this reason, everolimus as a targeted agent is generally favored over sunitinib. The other also being that everolimus, even though it's associated with toxicities, it's generally better tolerated than its partner sunitinib. The other type of medical therapy that you need to be aware of is CAPTEM. CAPTEM combines two drugs, capecitabine and temozolomide. Temozolomide, you will recall, is the agent that was used initially in the treatment of astrocytomas and continues to be. It works by acting on MGMT, which is a target in these tumors that also happens to be a target in neuroendocrine tumors. But what was discovered many years ago is that if you combine capecitabine and temozolomide, you maintain responsiveness to temozolomide longer than if you use monotherapy. The reason why I'm mentioning this particular combination is this is a therapy generally used for mid-grade neuroendocrine tumors. And importantly, it probably has a role to play in concert with PRRT, but we don't know exactly what sequence is best. And indeed, investigators in Australia now are beginning to look at how the sequencing of CAP-TEM with PRRT can be utilized most effectively. We also use embolization, as I mentioned before, and I'm just showing you data from our center here with John Katura, Interventional Radiology, demonstrating that as much as we like to use liver-directed therapies, the importance of taking out the primary is also crucial. So even though the patient may have metastatic disease, which is recognized at the time of diagnosis, dealing with the primary generally allows for better results, even when combined with regional or liver-directed therapy, as shown in this slide here. So now I'm going to move on to what you wanted to obviously hear the most about, and that's PRRT. And again, the reason for putting sort of the earlier information ahead is to really place PRRT in perspective. And what was happening in many parts of the country, including Ontario, is that we were sending a lot of patients abroad to Europe. As you know, it was costing us hundreds of thousands of dollars. And for that reason, our cancer agency put together an expert panel, which started its work really back in 2011. And I'm going to show you really what the outcomes were in this whole process and where we've gone, what funding we've received, and how we've been able to apply all of this. So our objectives really were to begin to really know how we're going to use PRRT, and this had to take place in the context of a structured clinical trial. We wanted to gain expertise. We wanted to also learn how we can use individualized dosimetry. And I have to emphasize actually and acknowledge the extremely helpful contributions from my colleague, Dr. Jean-Matthew Beauregard in Sherbrooke, who really was extremely helpful, along with others, on really helping us set this up, quantifying tumor dose, and also using things such as the Gallium-68, not in identifying patients for therapy, but rather in identifying early responses, which I'm going to show you in a minute. So we structured our trial to include patients that had well-differentiated neuroendocrine tumors. We used a cutoff of less than 30% to allow for inclusion of those intermediate cases that I mentioned earlier that were very problematic. But a key point here that we wanted to include is that patients would not receive this treatment until they went through a province-wide tumor board evaluation. And I will talk a little bit about that in a second. And that once the board agreed that this was a case appropriate for PRRT, that the patient would then go on to get the Gallium-68. And if it's positive, they would then go on to receive PRRT in a dosimetry-based fashion of 4 cycles every 6 to 12 weeks, with the primary outcome being the progression-free survival at 12 months. Secondary outcomes shown here, including RECIST criteria, as well as the toxicities. We had some tertiary outcomes as well that included the utility of the Gallium-68, as I mentioned here. But importantly, we really did not know what to do when the Gallium-68 was negative. One of the questions that was raised earlier was, what do you do in this situation? You go back to the OCT scan. And my belief is that at least so far, this has not been helpful to do an OCT scan, but rather in some of these bad cases is that we actually do an FDG PET. And there is evidence that sometimes the patients who go from well-differentiated to intermediate to poorly differentiated disease, they start to lose the somatostatin receptors and start to become more negative in nature and start to become FDG positive. And sometimes we even see a composite of 2, and that allows us to be able to identify those patients that we will pull out of this type of paradigm and give them platinum-based chemotherapy. So I wanted to tell you about our province-wide neuroendocrine tumors. These are virtual, and they've been virtual for the last 4 or 5 years, actually, well before COVID. So that was kind of helpful. And it included centers that really typically don't talk to each other. Let's be honest about it. We've got some fantastic people across the province and probably across the country, but because of our many obligations and the fact that we're far apart, we don't normally talk on a regular basis. This allowed us to do so every 4 weeks. We have to. Our patients would not get treated until we participate. And importantly, that we would share our expertise together so that we can offer, hopefully, the best possible opinion for our patients, especially when they may in fact be even seen in a center that's not particularly high volume in managing neuroendocrine tumors. We send out a call every month. As I said, it's every 4 weeks. By video conferencing, the images are shown, including structural imaging, the nuclear imaging, and allows for face-to-face contact. And there's a form that has to be filled out for that purpose, and it compiles all of the information so that then it becomes a complete opportunity to provide the consensus recommendations, which goes back to the treatment center and will be viewed by the patient as well, so they're aware that their case was reviewed and what the outcome was. This is just an example of the patients that we have reviewed, and we've had approximately about 120 cases almost a year. And just to show you, nearly 2/3 of these were thought to be appropriate for PRT. So again, it's not everybody, but and obviously this is somewhat of a bias because everybody's been excited about getting started with PRT. And I suspect over time, this may come down a little bit, but at least there is an opportunity to be able to explore other appropriate therapies where perhaps PRT is not necessarily the best thing at that time for that patient. The dosimetry, again, flows. I'm not going to show you, obviously, all of the details because you guys are the experts. But one of the reasons why this is so important for me as a clinician is to know that you guys are going to protect my patients' kidneys and bone marrow. Why? Because many of my patients will have been exposed to other toxic therapies in the past. And perhaps more importantly, that you're going to save the bone marrow and kidneys for me so that later on, when that patient progresses, despite PRT, and believe me, we've had so many of those, that I still have other options where the bone marrow does not become a limiting factor. In so doing, you can see here almost 2/3 of the patients were able to increase their dose because of dosimetry. We obviously did not want to go totally beyond certain limits. But again, this just shows you that there is indeed an opportunity to potentially safely go beyond the 200 millicurie per cycle in a good size of and proportion of patients, probably because these are resistant cases with significant disease and disease progression. And in so doing, again, this allows for normal exposure of the kidneys to tolerable levels that will not exceed the threshold of approximately 23 grays. These are just some images that I wanted to share with you, and I credit Rebecca Wong and Metzger from my institution. Here's the gallium-68 at baseline and before cycle number 2. And ultimately, you can see what happened with the structural imaging at baseline, quite a remarkable response. So it appears, at least in this patient, that the early gallium-68 may be informative in identifying whether this patient is ultimately going to respond structurally. Here's another example of a patient, baseline gallium-68 of disease that is quite measurable. And you can see here, again, on structural, almost completely gone. Now, again, obviously, I'm showing you, and this is biased. We do see cases where there is no such response, but at least there is some suggestion that the gallium-68 may be of value in identifying those patients who may ultimately get some benefit. And this is just to show you here in terms of what the pre-cycle number 2 scans were like, where there is at least 17 out of 33 in the initial 50 that we did, where there is an actual structural decrease by imaging. It's not always easy managing these patients beyond just giving them amino acids and protecting their kidneys and volume issues. We've had some cases where we've triggered crises, and I want to again emphasize that PRT can indeed worsen the situation acutely, and this is through release of preformed hormone, and you need to be aware of this because you need to protect those patients, and that's where you're going to need the medical people to work with you and not just sort of to treat these patients and leave them unattended. Obviously, it's too early for us to identify long-term toxicities, but you can see here most that are really related to the PRT have been relatively small so far. I want to emphasize this is a group effort, and we need good pathologists to tell us what disease we're dealing with. We need endocrine surgeons who can tell us how much debulking can occur. We need radiation oncology people to deal with resistant areas or possible cord compression that we don't want to find out after the fact, that we can do preemptively. And again, I want to emphasize the nuclear medicine component with Metzger, and as I mentioned earlier, my colleague, Dr. Beauregard, who's been extremely helpful in continuing to provide us with expertise and support in doing our work. Again, I want to emphasize PRT is not a panacea. It's a very important component in what I believe is going to be an evolving area of medicine. If you were to ask me as a physician where it's going, I will tell you that the concept is going to be with us to stay. The individual chelating and radioisotopes probably will change. And the reason why I say this is beta emission to target neuroendocrine tumors is probably worthwhile when a cancer is relatively well behaved and the chromatin and DNA is somewhat susceptible. But when it gets to be a little bit more advanced, we need something that's more active than that. And this is probably why some people are working on using alpha emission. Obviously, the benefits of gamma emission to be able to detect where the treatment actually resided is important, but we have to get around that. And the other, and perhaps more important aspect, which I predict is going to be where the future lies, is the different chelating compounds themselves. The backbone of the octreotide or related particles requires that the somatostatin receptor not just be present, but that it's present in the right conformation. And for this reason, people are now beginning to work on somatostatin antagonists. The advantage of an antagonist is that it can actually bind to a poorly formed or poorly expressed receptor. And this is where I think the future lies in managing these more resistant cases. So as I mentioned, I think this is an evolving area, and I think this is just the beginning, and I'm really looking forward to seeing more developments, and I hope this gives you a bit of a bird's eye view of where we are, and certainly we haven't been the leaders in Canada, but we're learning, and hopefully we will catch up very quickly. So again, thank you for your attention, and I'm happy to answer any questions. Thank you.
Thank you very much, Shireen. I guess it's the audience will easily understand why I have your cell phone number on speed dial. So Shireen has been my reference for any easy and complicated case, and as far as this type of disease, there is definitely no easy approach. For the longest period of time, we have seen cancer as very static entities. Not so. It's evolving over time. And as Shireen alluded to, the molecular biology aspect and the signaling cascade complexity make it such as there is no panacea for this type of disease. Feel free to send your questions, and I have access to them. Maybe Shireen, I know you don't have a crystal ball, but you have a background in molecular oncology, and I'd love to ask you the following questions. Among the many products, many compounds which are currently developed by the pharma industry, and you've seen a consolidation between the radiopharma and the pharma industry. Is there any compound which has been drawing your attention for this type of neuroendocrine tumor more than the PRRT compounds?
Look, so Jean-Luc, I have to sort of be very careful in how I respond to that. I'll divide them broadly into those that include isotopes and those that don't. Obviously, the what I call cold molecules are, people will ask, what about immunotherapy? And the fact of the matter is that immunotherapy has not proven to be very effective in this class of tumors so far, perhaps because, generally speaking, as they're well differentiated, they don't really get infiltrated with inflammatory cells as much as some other solid tumors or even melanomas. Having said that, there is a very small subset where I think immunotherapy may be of value, but this is probably very late in a disease progression. I do think that chromatin remodeling, how the DNA is compacted, is going to be where the future development is going to be. It's absolutely crucial. Let me be very specific about this. In the 1980s and 1990s, we worked on the cell surface, and all we could think of is the tumor has a receptor. If the drug, whether it's cold or radiolabeled, binds to that tumor, that's going to take care of it. And the answer is no, it's not sufficient. It's a necessary step, but as you pointed out, that cancer cell has to have vulnerabilities inside of it that will make it susceptible to either the signaling effect of that molecule or, for that matter, the release of whatever isotope that's going to damage the DNA. But that tumor has to be in a configuration that allows for this damage to occur. The receptor at the surface is only the first step in all of that. So that's been, I think, one of the lessons we've learned. So how we're going to be able to bind to the tumor at the cell surface, identify where the defects are, and be able to tailor a very specific modeling system that really personalizes the treatment of that cancer for that patient at that time. Because even when you look at the same patient with same disease, and if you biopsy them over 2 or 3 year intervals, their whole genome and epigenome is changing. So it's not quite so static, which is one of the reasons why personally I disagree with the declaration that PRT should be used for mid-gut, small bowel. I mean, guys, this is 1980s thinking.
Shireen, I cannot agree more with you. As you know, I have a background in molecular oncology, so we do realize the diversity in phenotype and genotype variation. Question for you, is there any promising pharmaceutical compound tackling the signaling cascade inside the cell that you see on the horizons?
Not that has been developed sufficiently, to be honest with you, Jean-Luc. At the very fundamental level, the answer is yes. However, I am not aware of any of the major companies having taken advantage of that, primarily because neuroendocrines have been considered to be not exactly the most attractive to develop new therapies. They've generally had what I call the hand-me-down syndrome, have a compound, and when they ultimately find that there is a potential for application in that disease, then they test it in that area.
Shireen, I have a question from a friend of mine. I'm assuming it might be in Saskatchewan, and I'm not sure he can enjoy the 20 degrees Celsius that we have on the east side of the country. It's from Glenn Ollenberger. And Glenn is asking a very interesting question. He said, is there a sensitive tumor marker for pulmonary carcinoid tumor? Chromogranin, it's not sensitive or specific.
Yeah, the question is spot on. chromogranin is a very promiscuous biomarker. And I have to emphasize, one of the things that we try to do as much as we can is go back to that particular patient's tumor. Have your pathologist do a panel so you know what the tumor is making and use that as your circulating marker. For example, not all pulmonary neuroendocrine tumors will make serotonin, and yet some medical oncologists will continue to measure 5-HIA. Well, that's completely irrelevant, guys. So my answer would be, again, it's not a generic, and it's certainly not chromogranin, but rather there is a panel specifically of over 20 markers that can be used and applied on that particular tumor, if it happens to be lung, or can be any of that matter. They can include things such as bombacin. There's another molecule called prostate-specific acid phosphatase, not PSA, but PSAP, that we often find in neuroendocrine tumors of the gut, for example, which is far more, not just sensitive, but far more specific, which I think is what the aim of that question was. So go back to the tissue.
Showing what you alluded to earlier, switching from beta emitter to alpha emitter, I think you were alluding to the fact that beta emitter goes single DNA strands breakup, while alpha goes double-stranded, and it's more difficult for the cell to repair. In the same vein that Glenn Allenberg questions, and based on what you said, what is the percentage when you see a patient and you have to decide about therapy, whatever the stage of the tumor is, what is the percentage of cases where you have available the result, I'm going to say the phenotype and the genotypic information in order to direct your treatment?
It's not as good as it is in the United States, that's for sure. And the reason for that is in Canada, where still different centers are trying to either develop their own molecular testing or sending it out. The trouble is that when you do it in-house, often you can't do all of a genome. This is not a whole genome. It's not even a whole exome. It tends to be a panel typically of anywhere between 100 to 200 highly prevalent mutations. But those are typically mutations that we find in common cancers like lung, breast, prostate. So I can tell you so far, most of our in-house molecular testing has not been very helpful in this disease. And for that reason, we're trying to work with other centers, both in Europe and in the United States, to develop more disease-specific panels. That's really what we need. It's not so much how quickly, because I get some very quick results, but often it's a very poor quality, has not been very informative for me so far, sadly.
Dr. Rizat, and that's a little bit of, we try to keep it a little bit as a secret so far, but in the spring of 2021, Dr. Izat and his significant other will be back with us, or we'll have a one-day session on theranostic. And Shireen, do you think that at the time you might be able to give the nuclear medicine specialist some additional information in terms of first what you're really looking for in terms of information of the nuclear medicine community, but also help the nuclear medicine community to decide about the appropriate use of gallium-68 dotatate, and eventually when they recommend PRRT. It seems to me, as you said, it's not a panacea. You know better than anybody else. Those who have embarked into a PRRT program also realize that you have partial remissions. I haven't seen a complete remission so far because probably you have advanced cases. So you think that over the next a few months and maybe a year or so, as we develop our theranostic program for the nuclear medicine community, you might be able to educate us and help us a little bit for the appropriate use criteria.
Jean-Luc, thank you for that. And thank you for the invitation and the kind words. I'm not sure about educating, but I will share with you what I don't know, which I think is very important. One of the things that really, I mean, there's so many aspects of this, which obviously I do not have time to get into, and that is salvage, retreatment, when to retreat, and when to stop. You know, it's very important. I mean, just because somebody started on treatment, you should not be so fixated. You have to do what's right for the patient. And this is really where the knowledge and the exchange of experience has to be ongoing and dynamic. And it's not just a matter of having to throw that patient off in your lap or vice versa. So you're absolutely right. I look forward to more discussions. I think you can imagine the multitude of questions and things that we can learn together on this, for sure.
Shireen, I have another request for you, which is I've been very privileged to meet your partner, who is a specialist in pathology, particularly in neuroendocrine tumor. So it would be fantastic if she would be willing also to educate us a little bit. Pathology, histopathology for us, I've been practicing for a while, it's all remote, so it would be good to get a little bit of a refresher so we can have our colleagues, the clinicians, the right question when they send us a patient for either for diagnosis or for therapy. For example, in the United States, they keep asking us, the insurance company requests that the Ki-67 be less than 20%. And most of my, and if it's higher, they deem that it's a de-differentiated tumor, so they're not reimbursed. So I think it would be good to educate the community in terms of which type of limitation we might face, which type of the questions we might have to answer to our insurance company, but also to our colleague asking us very pertinent questions.
Absolutely, Jean-Luc. If we have just 1 minute, I want to make this last comment. Do I?
We have 3 minutes. You have 3 minutes.
And I'm glad that you pointed out to the Ki-67. In fact, there are a number of studies now that show the extreme variability of how the Ki-67 is determined will influence the results. You can get the same patient, same tumor, in fact, not even different part, same tumor, give it to 3 different pathologists, and you will get 3 different results. And the reason for that is that in many instances, they do it by what they call eyeballing. Now, you know what eyeballing means. Eyeballing just simply means how dedicated that person is, how pedantic they are in looking at it. And it's, in fact, completely erroneous because we now know that you need software image analysis that scans the entire tumor so that you get literally thousands of cells and be able to create histograms so that this is far more objective with less variability than somebody having to eyeball and say, well, this looks to me like 25%. Or worse yet, I'm sure some of you will have seen reports where it says 3 to 21%. Well, what does that mean? So, you know, I think this is, for example, if I could put a plug in, you guys, and to some extent, Eric mentioned that, in the same way that you can guide ICU physicians to know where the tumor or where the infection is, you can tell us where to biopsy, when to biopsy, what are the resistant areas, and how we can do this together. So we're not actually just having you at the very end, but having you involved much earlier so you can help us work through this and do it much more intelligently and reliably.
So it's called precision medicine. Shireen, I really like to thank you very much for taking time out of your weekend to talk to us. I'm sure that everybody appreciates your in-depth knowledge of the disease. One thing I can promise you, I don't think it would be a gift to you. I will not share your cell phone number because it would not stop ringing days in and days out. Thank you very much, Shireen. Say hello to Sylvia for me.
I will. Thank you. And have a good afternoon, everybody. Thank you for the invitation. My pleasure. Thank you.
Thank you. I'm assuming that Andrew will come on board.
I think Nicola is going to take over from here, Jean-Luc.
Okay, very good.
Well, thank you very much. We will now go straight into the PM break. In the sponsors exhibit, we had a little surprise for you. It was a relaxation period just to kind of clear our minds. We didn't have enough time to do it. So how about right now, before we close up this day with 2 more speakers to come, let's take a little break, relax, breathe a little, and we'll come back in 15 minutes, all nice and refreshed. Enjoy.
Hello, everyone. My name is Jess. Thank you for being here, for bringing your minds, your attention, your energy to this day. I know that if you are here, you are in a position of service, and through your work, your offerings, your minds, your intention is to do good, to heal this world. And I want you to know that your work does not go unappreciated. It does not go unnoticed. It has a ripple effect across the globe, and you likely do not see the impact enough. So I'm here on behalf of the collective to say thank you. My intention here today is just to give you a little bit of peace of mind. The peace of mind that you give this world through your daily doings. It's a pleasure to guide you through these little moments of breath, of pause, of stillness. So join me. We'll get started by uncrossing our legs, no matter where you are. I'm on my couch. I was on a meditation cushion, but I figured that you likely wouldn't be on that this morning, this afternoon. But if you are, I really want to be your friend. So that's really cool. So I'll ask you to uncross your legs no matter where you are, and you're going to plant your feet into the ground. Perhaps they're in shoes or in slippers, wherever they may be. Just come to a comfortable seat. We'll go through the postures in a little bit. Anchor all 4 corners of the feet into the ground, signaling to your body to be present and root into this moment, into this breath. And then close your eyes now. Pause. Open your ears in presence and self. Now, bringing awareness to your spine, I'll ask you to slowly roll yourself upright. Crown of the head shooting towards the sky, which gently guides the chin downward. There's no need to perfect this. If you need to slouch, please do. We have enough pressures in our lives that relaxation does not need to be one of them. Ironic, isn't it, that we rush to relax? We have a phone that nags us to be mindful. I broke up with Siri a long time ago, and I have Bixby well trained. So just breathe. Now take a big inhale into the belly. Just fill your belly, your lungs as much as you can. Exhale, let it go, squeezing the belly, rinsing it out. And again, 2 more times on your own, not worrying about those around you. Allowing yourself to come back to this moment for you. You might notice that it's hard to inhale and fill yourself, and that's normal. You've been filling yourself with knowledge all day, and it gets stored in the body. So this is your time to pause, reset, and let it go. Now bringing awareness to your hands, Usually the traditional posture you see is your palms facing towards the sky on your lap. This is a gesture of service, of offering, and also of one being open to receive. But I know all of you give on a daily. You give yourself, your time, your mind, your knowledge. So I'll ask you to take your hand and flip your palms back down onto your lap, softening your hands, your fingers. This signals to the body that you are giving back to you. Mindfulness does not have to be a big task. You don't have to escape on silent retreat. It just takes a moment or two a day to pause. And now notice your elbows. Bring them back, if they aren't already, closer to your rib cage. And you'll notice right away how your chest lifts to the sky. In our lives, we're constantly reaching for goals, for dreams, and that's such a beautiful thing. Now is the time to bring it back. Your shoulders back, your elbows back. Take that energy back within. Now, moving on upwards into the body, taking that awareness from your hands all the way up to your shoulders. Inhaling, guiding your shoulders up to your ears and slowly rolling them back, opening the chest forward and down. And again, these slow shoulder rolls. No need to do it quickly. Getting all the kinks out. Maybe swaying. Literally nobody's watching unless you have somebody at home. Getting out of that mold, that box, that chair, that shape that we try to fit ourselves in every day. And go, maybe swing the head. Pausing wherever your neck needs it. Maybe your ear tilting over to the right shoulder. Inhaling here. Coming back to center, other side, left ear to the left shoulder. Pausing here. Taking a breath. Breathing space into that right side of the body. Exhale, let it go. Coming back upright. And breathe. And now bringing awareness to the center of your forehead, that third eye, the center of intuition, the all-seeing. This eye here is called the eye of the eyes. And it's the person that sees, the person that comes forth when we shut everything out, everything down. The person that surfaces when we've closed a door at the end of the day, closed our curtains. That simple you. That simple you that gets buried by busyness, by doings, by responsibilities, by pressures. And that's okay. It's just to be mindful. So let's bring to mind if this deeper you could speak. What would it say? Would it tell you to rest more, to soften, to be more compassionate towards yourself, to others? Or would it tell you to go after that project, that idea, that goal that you've been holding within? All life needs rest and incubation in order to come alive and flourish again. All we have to do is take one look outside right now to see the plants. Nature understands that in order to be reborn, it needs to come back within. Now I'll ask you to join me to take one hand to your heart, connect to that beat, that pulse beneath it. And if your mind is aching to let you go, to wander, to move, pause. You need it most. And when the world is pulling you every which way, pulling your hands, saying, this is important, this is important, I need you here. I ask you, even if for a moment or two a day, to pull your hand back, pull it back on your heart, and say, no, this is important. And take a big inhale. Exhale, let it all go. Drop. Soften. And allow this moment of stillness, of peace, to be carried into the rest of your day. From my heart to yours, I thank you. Thank you for being here, for creating this time and space for you, and thank you for all your work in making this world a better place. Namaste.
All right, we're back. We hopefully are all feeling well rested and centered and ready for the last couple of sessions, as it is even when a live meeting when you're in this time of the afternoon is usually siesta time when people start to kind of fade. But I think we have a couple of really great lectures still to come. And so hopefully everybody is ready to put in for the rest of the session. While we're getting teed up, I will just follow up on Dr. Urbain's comments from that excellent discussion on nets. We are planning the next big day-long session in hopefully April. It's going to be focused on theranostics, a Canadian perspective and viewpoint. We hope to have it as a fairly wide-ranging discussion, and we will have experts from across the country hopefully to be able to present. And in the meantime, as said, generally on a monthly basis going forward, we will have webinars, so stay tuned to the CANM website and register and join in, and hopefully we will continue to be able to provide this. We're moving forward. This is sort of a follow-up, kind of a sequel to Dr. Urbain's webinar of a couple of weeks ago. And it's called cardiac theranostics. I remember the first time I heard Jean-Luc use this term, it kind of stopped me in my tracks because I had never really thought of nuclear medicine as a theranostic viewpoint from the cardiac standpoint, but he makes a very strong case for it, so we'll hear about that. I had the pleasure of working with him today as a co-moderator, but I want to take the opportunity to formally introduce him to the audience. Dr. Urbain is an august personality. He is truly a world individual in many ways. Born and native of Belgium, that's where he received his both his medical degree as well as his internal medicine and nuclear medicine training and certification. But then he migrated to the US and went to Temple University in Philadelphia, kind of a big state today, as we've seen, as things have kind of come across that we have the new president in the US, and that comes out of his old alma mater state. And also a very pertinent kind of training, as we've heard when he had the discussion with Dr. Ezat earlier about the molecular aspect becoming far more salient to our specialty as we move forward. He has held the professor of imaging and medicine and biology in various institutions, including Western Ontario in Canada, the Cleveland Clinic, the Fox Chase Cancer Center, and most currently at the Wake Forest University Baptist Medical Center. He has numerous professional and other involvement, including president of the Canadian Association of Nuclear Medicine, and he was taking on, as of January 1st, the presidency of the World Federation of Nuclear Medicine and Biology. So without further ado, I will turn the floor over to Jean-Luc to talk about cardiac theranostics with us. Thank you.
Thank you very much. Andrew. What I'd like to do, and I apologize if the image might be a little blurry, that's because the sun is shining through my window and I don't have a blind on that small window. I need to share my screen. Nicola, can you go back for a second? I need to change the screen that I'm going to share. Thanks, Andrew. Thanks, Nicola.
Blinded by the North Carolina light. There you go. You're on board now, Jean-Luc.
Okay, very good. What I'd like to do this afternoon is fly over one aspect of nuclear medicine, which I believe is going to be, if not bigger, at least as big as nuclear theranostic as it relates to oncology. When I give a lecture on theranostic, I don't have any conflict of interest, to be clear. When I talk about theranostic, I always like to remind people that we have used medical isotope for the diagnosis and therapy of disease for a very long time. And for those of you, none of us hopefully were born at the time, I believe, but for those of us who can remember the history of nuclear medicine, sodium iodide has been used since 1941 for the diagnosis and therapy, and is still used today as a key element for thyroid disease, particularly hyperthyroidism and thyroid cancer. Now, the word theranostic, as you probably know, that's a contraction of the word therapy and diagnostic. The concept actually was put together in 1998 by a gentleman named John Frank Hoser, and his concept was that what about if we offer, and he came from the pharma industry, what about if we offer in a single package a diagnostic and a therapeutic test? And nuclear theranostic basically you can label compound with both the diagnostic and the therapeutic isotope, and then you have basically a diagnostic and therapeutic tool. We were helped tremendously by Human Genome Project, which has basically unraveled and identify what's called the oncogenotype and the oncophenotype of tumor. So current nuclear theranostic in oncology take advantage of the overexpression of receptor at the surface of cancer cells. And as you know, we can use, we have available both diagnostic imaging isotope and therapeutic isotope. But what I like to remind people is that beside the 3 compounds which are currently approved, at least in the United States and in Canada, there are a fair amount of new compounds coming up in oncology. That being said, if we go back to the early concept of theranostic, which basically refers to the availability of a diagnostic and therapeutic tool to manage the patients, I think we can play a major role in the management of patients, particularly in cardiology. So I think, to me, theranostic goes far beyond that nuclear theranostic. Nuclear theranostic is probably only 10% of the overall theranostic business. So I want you to think big, I want you to think large, and I want you to think that we can offer our colleague clinicians current, and hopefully I'm going to have you dreaming a little bit of cardiac theranostic with the other numerous radioactive compounds which are coming up in molecular cardiology. I don't know if many of you have seen this image. It dates from 1975 with Eliak Botvinnik, basically showing that PYP, pyrophosphates, could label infarct in the dark, inferior infarct, that's the middle part of the slide, and anterior infarct, that's the right side of the slide. Actually, pyrophosphate is a very ubiquitous metabolic byproduct of many intracellular processes, which is found in most cells. And it can also be produced extracellularly. As you know, we can buy it. We discussed that about a month ago. Pyrophosphate is actually an organic compound, which is a very potent inhibitor of calcification. And it antagonizes the ability of inorganic phosphate to crystallize with calcium to form hydroxyapatite crystal and deposit anywhere in the body. So the take-home message here is pyrophosphate is not a new compound, and it's an endogenous compound that we can also buy from synthesis and use in our practice. I really like this title. That came a year or two ago. Nuclear medicine and tools in medicine is pretty much like the fluid fashion industry. It goes in and out. So pyrophosphate, the way we use it now is very different than looking at INFARCT. Dr. Dorbala, who will be the last speaker today, will cover this at length. But as you know, now we can use in a very efficient manner pyrophosphate for the diagnosis and to some extent the prognosis of ATTR cardiac amyloids. I will leave Dr. Dorbala expand to that. The reason I'm bringing this is because we can play a major role not only in the diagnosis but also in the prognosis of cardiac amyloid, and eventually also in the patient management by telling or referring a colleague from cardiology the patient might benefit or not from this type of new treatment, either a decrease a compound would decrease the synthesis of transthyretin, which is the protein which carry tyrosine and retinol, or to stabilize it, such as there is not so much deposits in the eye. Another infiltrative disease where we can play a major role in terms of diagnosis and prognosis is cardiac sarcoidosis. It's not necessarily a very easy diagnosis to make. The involvement of the heart by sarcoidosis granuloma can be quite ominous. And it's believed to involve the heart in about 20 to 30% of patients with systemic disease, and also the heart might be the only organ which is affected. It's not an easy diagnosis. Those of us who have the ability to have a PET scan, basically pretty routine with the new protocol. When you look at cardiac variability, you want to make sure that the myocyte, the cardiac muscular cell, take up FDGs, a little bit the opposite. When we look at cardiac sarcoidosis, we want to image a macrophage, we want to image an inflammatory process. So I have illustrated at the bottom of this slide, basically the different preparations and the way we can eventually diagnose cardiac sarcoid. There is some published algorithm that you can rely to, and you can look at in order for the interpretation of cardiac sarcoidosis with PET18 FDG. My experience is not that easy, and if for those of you who would eventually embark into that beside oncology, we definitely have to have gated images to move into that direction. The reason why I like to talk a little bit about this is because we can play a major role in those patient management. This is basically a very obvious positive case when you see at the level of the heart multiple foci of increased FDG uptake. That's a baseline study on the left. And then after treatment, as you can tell, disease is progress. And there are also sarcoid deposit at the level of the spleen. So it's a good indicator of patients' disease progressions, or in the next case, you see the extensive mediastinal cardiac disease, splenic, and even abdominal disease on the left side of this slide. On the right side after treatment, and the treatment, as you know, essentially based on cortisone and or some chemotherapeutic agent, basically the disease, sarcoid disease, has been wiped out. So I consider this test as part of cardiac diagnostic. We don't necessarily have a nuclear compound to treat those patients, but we can play a major role into their management. Another thing which we have available in order to help our colleague to manage their patients, not only in terms of sarcoid, but in terms of cardiac insufficiency, for example, is MRBG. MRBG has been around for a long time, and actually it's somewhat of a serendipitous outcome. Initially, MIBG was developed not for cardiac, but was developed as a marker for the adrenal glands and for adrenergic tumor. And we take advantage of this to look at the innervation of the heart, or the lack of innervation, particularly not only in infiltrative disease, but also when the patient is evolving into heart failure. As you probably know, for those of you who are using MIBG, the determinant factor is basically the ratio between the uptake at the level of the heart, which is a reflection of the receptor, the adrenergic, the postsynaptic receptor at the level of the heart, versus the mediastinum. Many studies have showed that basically you need to have, if you have a ratio which is about 2.2, you still have good innervation of the heart. Below 2.2, that can be a little problematic. And these are three cases. The cases on the left, basically, that is a 79 years old patient with a non-ischemic cardiac insufficiency with a ratio of heart to mediastinum of 2.02. This patient had no significant cardiac event over the next 5 years after this test. The middle part of the slide is 64 years old female, again with a non-ischemic dilated cardiomyopathy and EF of 25-30%. Our heart to mediastinum ratio was 1.38, and this patient experienced numerous arrhythmic events and ICD discharge over the next 2 years after this scan requiring a VT ablation. Finally, a very young patient, 28 years old, on the right side of the slide, an ejection fraction, left ventricular ejection fraction of 20%, and an HMR, heart to mediastinal ratio of 1.17. This patient progressed very quickly within a year to end-stage cardiac disease. One aspect which is not very necessarily understood or well known is that you can also use fatty acids to diagnose retrospectively cardiac ischemia. On the baseline basis, the heart, as you know, essentially, particularly when it's non-ischemic, is using fatty acid as its main fuel. There's a little bit of glycolysis used. There's also some glucose oxidation. We see this days in the desert when we perform oncology PET scan with FDG. But look at what happened. That's the right side of the slide. In an ischemic pattern, basically the glycolytic component and the glucose oxidation become predominant at the expense of the fatty acid oxidation. And the reason is because energetically, it's faster and easier for the cell to use glucose oxidation and glycolysis. Well, you can somewhat take advantage of that. At the top of the slide is basically a stress perfusion scan. Lower row is the rest, and as you can tell, there is inferior interseptal ischemia. And if you do an FDG on this patient, basically you're going to see a significant amount of FDG uptake. We know that the inferior interseptal area is viable because the rest is normal, and it's viable, but it's using FDG instead of using fatty acids. Now, on this slide, what you see on the left side, it's a thallium study. You see that the stress images again show an inferior defect, which fills in during the rest. So the patient has inferior ischemia. This patient was injected at the same time than the stress images with a fatty acid labeled with iodine 123 at the right side of the slides, and images after an hour or two. The images taken 1 or 2 hours after the administration of the tracer showed a deficit of fatty acid uptake and metabolism to the inferior wall, where basically you had the deficit on the stress test. These images were actually taken 22 hours after the stress test. So this is what's called the cardiac ischemic memory. I don't think this compound is not approved in the United States. I don't think it's approved in Canada. But at one point, as we evolve into more molecular imaging, cardiac molecular imaging, as part of precision medicine and retrospective diagnosis, that might become an isotope and a radiopharmaceutical that might be of interest. I was privileged to attend one of the SNMMI lecture in July during their meeting, and I was fascinated by the opportunities and the challenge, but also the opportunities that we have in front of us in terms of being part of the cardiac patients management, cardiac disease management. Chronic heart failure is associated with what I'm calling a neurohormonal activation, you have a thunderstorm, you have a significant increase in epinephrine, norepinephrine, but you have also a significant activation of the angiotensin converting system, the inhibitions. You have a major activation of the angiotensin system overall. And that system, the angiotensin system, basically play a major role. The renin-angiotensin system play a major role in what's called left ventricular remodeling and fine-tuning that's expression of angiotensin converting enzyme, modulating the receptor, the blockage of this receptor has been used probably over the past 5 years by some center in order to get a better outcome and a better left ventricular remodeling. And it's somewhat easy to understand. The more fibrosis you have, the less functional your heart will be, and the worse the prognosis of your patient will be. So if you can help the cardiologist, giving him information about the expression at the surface of myocytes of the angiotensinogen receptor, for example, or give him information about the angiotensin converting enzyme level and eventually inhibition, I think that you're giving useful information to the cardiologist about fine-tuning his patient's management. Another very important aspect here is the fact that we have available, that's research-wise, that's available, angiotensin converting enzyme. Most of them are labeled with fluorine 18, but lisinopril, for example, can be labeled with technetium. So we can image in nuclear medicine the angiotensin converting enzyme levels. Angiotensin converting enzyme basically is at the surface of the cell, so you can give the cardiologist some information about how much that renin-angiotensin system is activated, and you can eventually block it. The angiotensin 2 type 1 receptor compounds, right now they labeled with C11. There's another one which is labeled with technetium 99M. So it's research-wise, it's available, and my hope is that at one point one of these compounds will be available clinically, and we can play a major part or a better part, a greater part in the patient, in the management of patients with cardiac disease. And this is basically, I like to focus on the slide on the right. That's a patient with an anterior infarct, and on that anterior infarct, basically in some area, you still have expression of the angiotensin receptor, which is not necessarily shown in perfusion. So giving that information to the cardiologist will help him to decide if the management of the infarct and the management of the left ventricular remodeling works, doesn't work, and at the very least to optimize it. A very interesting compound, which has also been somewhat published and promoted over the past probably 15 years, is the annexin 5, and the concept and the molecular biology process of apoptosis. So apoptosis is defined as basically cell death, program cell death. There are essentially two types of apoptotic pathway. One which is figured out on the left side of this slide, is called the intrinsic apoptotic pathway. And you have an insult at the level of the cell for whatever reason, and the cell will basically trigger a signaling cascade, which ultimately will end up with the death of the cell. But there is another pathway which is also used in the body. We have some receptor and some molecule binding to those receptor, like TNF alpha, which induce apoptosis at the level of organ and cells. We can take advantage of the apoptosis in our program cell death because annexin 5, which again, it's an endogenous compound, and of course you can synthesize it, but basically it binds to the phosphatidylserine residue, which are basically pictured here at the surface of the cells when it's dying. So annexin 5 can be labeled with positron emitter. It can be labeled with a single photon, and you can basically, in today's world, at least for research, you can also evaluate the extent of an infarct or of the apoptotic mechanism, the apoptotic cells at the level of the heart. And that's what it shows on this slide, where you have basically an anteroseptal scar here. This is a right ventricle, the septum, the lateral wall, the apex. You have a scar here on the MIBI study. And as you can see on the left side of the slide, you have also an uptake of annexin. Other compounds also bind to these phosphatidylserine residue, like for example, duramycin. And duramycin can be labeled with technetium, I believe, and so it's being investigated right now. This is an animal model with an apical scar and the labeling of that scar with the compound duramycin. Another potential use of annexin 5 is on this patient as an unstable plaque at the level of the left carotid. You have intense increased uptake of annexin 5 in comparison, for example, of a patient who might have a plaque but which is not unstable. So once again, it can play a major role in this patient management, either medical management or the placement of a stent or the removal of the thrombus or the removal of the plaque. Not easy to treat a patient with atherosclerotic plaque. It's a very complex, but in today's world, well understood pathophysiology. And the reason I'm showing this slide is because, as you know, part of the process, the pathology of plaques is a migration of monocyte and macrophage into the neointima, just above the muscle of vessels. And if you can take advantage of this because now we have a very good understanding of the different signaling cascade, the different inside the cell, the receptor overexpressed at the level of those monocyte and macrophage throughout the history of toward the evolution of those vessels plaque. This gives you a list of basically potential target for us. It's also used by MR researcher to do imaging with MR. And I'm going to hand up with three quick slides. One is this is a molecule called chemokine receptor 2. There is an animal model which shows that you can predict basically a rupture of a AAA if you inject this molecule, and I think it could be very effective when we have a patient with abdominal pain and we suspect a AAA. After infarction, there is a migration of myofibroblasts inside the infarcted area, and that's what the prior slide showed. On this slide, basically what I'm showing is myofibroblasts and the number of receptors which have been identified at the level of those myofibroblasts. So it's easy to imagine that the more myofibroblasts you can eventually use to replace myocytes, maybe the prognosis and the left ventricular remodeling will be better. So the future is definitely to be able to label those receptors at the level of the myofibroblasts in order to evaluate the healing process and the remodeling of the left ventricle. And finally, what is currently being developed in labs, and this study basically showed the extracellular matrix of the heart. There are multiple targets at the level of the extracellular matrix of the heart that you can target in the normal heart, but also in the diseased heart. This shows essentially the targeting by some of these molecular targeting of collagen and collagen assembly at the level of myocardial infarction. Through this slide and through this brief presentation, I wanted to show you basically what could be nuclear theranostic and theranostic for us in the future as it relates to cardiac diseases. We in nuclear medicine are dreamers, and we need to keep dreaming in order to make progress. Thank you very much, everybody.
Thanks. Thanks very much, Jean-Luc. Great overview, great talk as always. We are moving along with things. I have not seen any questions roll through yet. I suspect it's a mix of a very comprehensive discussion and the siesta kind of time of the day that I was referring to before the talk. If anybody has any questions, please feel free to send them along. We will, in the meantime, we will just, Dr. Urbain, is there any, where do you think the most likely next radiopharmaceutical into the cardiac clinical role will be based on what you've seen, what's currently not there, or perhaps the newest or next application of an existing or old one?
Good questions, and I don't know what the status in Canada is at this point. When I was at Western Ontario, basically we were asked by a company, Lantheus, to do a phase 2 clinical study with Referrals, labeled with F18. You can do cardiac perfusion, as you know, with maybe MyoView and some thallium. It's in today's world, I think if you want to calculate cardiac flow reserve, regional flow reserve, it's better to turn to ammonia or to turn to rubidium. These compounds are not necessarily easy to synthesize, to get available, and are very costly. Flurizepaz is basically a better compound to use. I think more easy is going to come as a unit dose, so those having a PET scan can use it. Will be able to do stress and rest pretty much like we do maybe in MyoView on the PET scan, and have a greater resolution. So that would probably be the first one. I think FDA is supposed to approve that early in 2021. The next one will definitely, I think, be maybe Annexin 5 for the apoptotic pathway. And I have great hope that the compound that I showed you in terms of the ACE inhibitor, but also the angiotensinogen receptor will come to the surface and will be able to basically fine-tune and help our colleague in cardiology to optimize their treatment. I think that's the beta blocker, the ACE inhibitor, and some of the aldosterone or anti-aldosterone compounds which have been used over the past 20 years to treat myocardial infarction, beside the TPAs or after the TPAs and the angioplasty and the placement of stents still need to be improved. So the more information we give our colleague in cardiology in the coronary care unit, basically the better they'll be able to modulate their treatment, refine their treatment, and hopefully improve prognosis and survive all of those cardiac patients.
All right, one question before we move on. There's a question from Jean-Luc Villemer. Just a great lecture. How many cases of pyrophosphate do you do, say, in a month at your institution? Is it often in cases of cardiac failure?
I'm going to give you a very pale number, I'm sure, compared to Dr. Dorbala. We do an average of 2 to 3. We do both planar and we do SPECT CT images. I'm sure Dr. Dorbala probably is doing, and she'll tell us in a few minutes, she'll probably do 2 or 3 a day, PYP, and I'm sure she will extend that too. So it's definitely very useful. The cardiologists use it, but you need to know what the limitation of the technology is. And again, I'm sure that Dr. Obala will talk a little bit about that.
And I think that's a great segue, Dr. Urbain. I'm going to hand over the floor to you to introduce our last speaker of the day and the topic.
Thanks, Andrew. I was privileged a few years ago. I've been privileged for about a little less than 10 years to organize a scientific meeting of the CANM, and I was privileged a few years ago, I don't remember which year, to invite, we have a partnership with the American Society of Nuclear Cardiology to invite Dr. Sharmila Dorbala to talk about nuclear cardiology. And to be honest, I don't really remember when she came. It could have been Calgary, it could have been Toronto, I'm not sure. I remember I was privileged to meet her. And at the time, she shared with me that with one of my other colleagues, Marcelo Di Carli, she was heavily embarked into cardiac amyloids. They have pretty much all the tools that you can dream of to do nuclear cardiology. So I was quite excited. She is the author of numerous publications on the subject. She wrote most of the guidelines, not only in North America, but probably also in the rest of the world. She's professor, she's the director of nuclear cardiology at the Brigham and Women Hospital and a professor at radiology at the Harvard Medical School. So Sharmila, thank you very much for coming and highlight us about your expertise, your incredible expertise in this field. So Sharmila, I saw you briefly. If you can activate at the top right of your screen, you should be able to activate your camera and your microphone. Look like Dr. Dorbala might have had some connection difficulty.
She was there and ready.
Can you hear me now?
We can
Yes.
hear you, Sharmila. Can you, if you cannot activate your camera, that's fine. We'll love to hear from you. But if you can activate your camera, it might depend on your bandwidth.
Okay, as long as you can hear me, can you see my screen as well?
Not only we see you, but so next phase is to share your screen, and Nicola in the background should give you, basically, you see at the top right, perfect, great.
You're able to
So
see that?
if you, we're able to see that if you go into basically the slide view mode, the presenter mode, that would be good, and I will vanish in the background.
Okay, hold on. So you're not seeing the presenter mode right now. Okay, hold on.
We see
No,
your
no,
first
no,
slide.
you are. We are seeing it. You're good to go.
You're not seeing my notes, right?
No, just you need to start your slideshow.
Yeah, I'm already showing my slideshow. So hold on 1 second. So I don't know.
If you have two monitors, I think you might show, depending which monitor you're sharing.
Okay.
Yeah, perfect. Perfect.
We're on.
Thanks, Sharma.
Perfect. Thank you so much. Sorry for the little technical glitch up front, but I'm really pleased to be here. Thanks to Dr. Bain and Dr. Ross. It's really an honor to present at the CANM Virtual Congress for 2020. These are my disclosures. As an outline, what I wanted to talk with all of you today is give you a little bit of background about amyloidosis, then talk a little bit about AL and ATTR cardiac amyloidosis, and end with a little bit on clinical practice guidelines. We all know that amyloidosis is not a new disease. It was described as early as in the 1840s. In 1980s, early 1980s is when it was discovered that cardiac uptake on bone scintigraphy represented cardiac amyloidosis. And there were a lot of studies and activities during the 80s and 90s with publications using bone scintigraphy for amyloidosis. However, the results were highly variable. Some studies showed high sensitivity and others showed low accuracy, high accuracy versus low accuracy, and people were not clear exactly why this tracer was working sometimes and not other times. Then subsequently in the early 2000s is when folks in Europe discovered that the bone avid scintigraphy was more specific for the TTR form of disease than the AL form of disease. And this discovery led to this discovery and revelation led clinicians to apply this technique more for TTR amyloidosis, and that opened up an entire area of research and clinical applications. In about 2012 was the first approval for a PET radio tracer for amyloid imaging. It was fluorobutapir for beta amyloid imaging, and subsequently we have at least 2 other tracers that were approved for beta amyloid imaging. In 2015, we saw the first publication of a study looking at screening for ATTR cardiac amyloidosis in patients who were hospitalized for heart failure using bone avid scintigraphy. This really opened up a whole new area of clinical research as well as clinical early detection of disease with TTR cardiac amyloidosis. In 2016, there was a multi-center document that was published. I'll share with you more details of that. And of course, in 2018 and 2019, we have approval of treatments for TTR cardiac amyloidosis. So the initial approval was for gene silencers for TTR neuropathy. And then in 2019 was the first TTR stabilizer, which was approved for treatment of cardiomyopathy. And then in 2019, the societies got together and published a multi-societal consensus recommendations document on use of imaging for diagnosis of cardiac amyloidosis. So what are amyloidosis? This is a large group of biochemically and clinically heterogeneous disorders that is caused by protein misfolding. Systemic amyloidosis, Alzheimer's disease, Parkinson's disease, diabetes type 2. So many diseases are now felt to be caused by protein misfolding. The key common factor for all of these disorders is that independent of the precursor protein, when these proteins misfold and form fibrils, they have this classic beta-pleated sheet structure with this configuration. And this is important, and I pointed out here because some of the tracers that are amyloid imaging tracers, they bind to these the beta-pleated structural motif, not necessarily to the precursor protein, but to the components of the fibril that hold the fibril together. Because of this property, these tracers are able to bind to amyloid independent of the precursor protein. So what I mean is beta amyloid PET tracers have been shown to work for AL in ATTR amyloidosis, we believe because of this reason. So the two common forms of amyloid that affect the heart are called the AL and the ATTR cardiac amyloidosis. AL, or light chain amyloidosis, is formed by misfolding of immunoglobulin light chains. It's a plasma cell dyscrasia with a rapidly progressive clinical course. Treatment here is to treat the bone marrow using chemotherapy. If untreated, median survival in patients with AL amyloidosis with cardiac involvement is about 6 months. The other common form that affects the heart is ATTR cardiac amyloidosis. This exists in two variants. One is the hereditary form, which is an autosomal dominant inherited disease. The other is the wild type form, which is a disease of aging. Both of them, in fact, AL and ATTR together, present with heart failure. Neuropathy is more common in the hereditary form of disease. The TTR form of disease is slightly slowly progressive compared to the AL form of disease. The treatment has been stabilization of the TTR. In the neuropathic form, in the past, before there were gene silencers, liver transplant, they used to transplant the liver because the liver produces the transthyretin protein. And liver transplant was used in the past, and we don't believe it will be used in future. The median survival in the TTR is better than the median survival in the AL form of disease, but still think of the median survival of 7 years after the onset of heart failure. These are patients in their 40s and 50s, particularly the ones with the hereditary form of disease, and the median survival of 7 years is very, very low. So this is a schematic that shows you the formation of the TTR fibril. So the normal TTR protein is a homotetrameric structure with 4 components to the TTR protein. These components, if they get unstable for any reason and dissociate into dimers or monomers, these forms are more prone to aggregation and fibril formation. So these dimers and monomers form fibrils. They lead to what are called oligomers, smaller chains, amorphous oligomers, and eventually fibrils. Because the rate limiting step here is the dissociation of the tetrameric form into dimers, folks have actually developed treatments where you can have a structure here that binds to this tetrameric form to stabilize it. So that one of those drugs is tafamidis, and AG10 is another drug which is also a TTR stabilizer. And this is the mechanism of action of TTR stabilizing drugs, in that they hold the tetrameric form, prevent the breakdown into dimers and monomers, thereby prevent formation of new fibril. So what are the imaging targets in cardiac amyloidosis? So here's a schematic showing a cardiac structure, left ventricle and right ventricle, and here's the cardiomyocytes with, in pink, extracellular space. The heart muscle can thicken and result in left ventricular hypertrophy, as in diseases such as hypertension or aortic stenosis with increased afterload to the ventricle. And then you see myocyte hypertrophy with some expansion of ECV, typically manifesting as high voltage on ECG. In contrast, you can see biventricular wall thickening from infiltration by amyloid fibrils. And then what you notice here is the cardiomyocyte size may remain normal, may sometimes be even smaller than normal, but the extracellular space is substantially expanded by this amyloid fibril infiltration, resulting in thickening of the ventricles, right and left, interatrial septum, valves, and all other manifestations. These patients sometimes can show a low voltage ECG, typically in the AL form of disease. Normal voltage or high voltage does not exclude amyloidosis. So that's something to keep in mind. And we know that increased wall thickness, both LV and RV, is well imaged by echocardiography as well as by cardiac magnetic resonance imaging. However, the extracellular space expansion, the only technique to image it at this point is using cardiac magnetic resonance imaging, and ECV expansion is a classic feature of amyloidosis. But the most specific way to image amyloidosis would be to use targeted imaging agents that bind to the amyloid fibril. So radionuclide tracers, whether it's SPECT or PET tracers, appear to be specifically targeting the amyloid fibril, therefore provide a much more specific signal of amyloidosis. Importantly, it's good to know that in the light chain form of disease, in addition to the infiltrative process that is demonstrated here, these patients also can have interactions between circulating light chains and the amyloid fibril, resulting in local cardiotoxicity. At this time, we have no real imaging methods to image cardiotoxicity. It is assumed based on elevated cardiac biomarkers, either NT-proBNP or troponin T. Biopsy, one would think, would be an important way to diagnose infiltrative diseases. And in fact, in AL amyloidosis, biopsy is essential for giving chemotherapy for these patients. It has a sensitivity of 84%. Usually it's either a fat pad biopsy, bone marrow biopsy, or an involved organ such as kidney that's biopsied. Fat pad biopsy, however, has a limited sensitivity for ATTR. It's about 45% sensitive for the hereditary form of disease and really only 15% sensitive for the wild type form of disease. Because of this reason, before the advent of imaging techniques for TTR amyloidosis, the only way we could detect this disease was endomyocardial biopsy. So as you can imagine, the doctors really did not send patients for an invasive endomyocardial biopsy unless they were reasonably certain that it was amyloidosis. So this typically resulted in diagnostic delays and detection of disease at an advanced stage. What we are seeing now in clinical practice is we are suspecting the disease at an earlier stage and able to detect it using imaging at an earlier stage. The other challenges with biopsy are that expertise is required to interpret the biopsy results, and we'll talk a little bit about imaging. In the current era, with the advent of all these bone-avid scintigraphy, endomyocardial biopsy is now reserved for cases that are challenging to interpret, where there's discordance between the clinical manifestations and imaging findings, or where the patients have some form of manifestations of AL amyloidosis that is not easily detected. Echocardiography can show a infiltrative process, but it is not sufficient to distinguish hypertrophic heart disease from amyloidosis or to distinguish AL from ATTR amyloidosis. The most common manifestations are thickened ventricles, valves, large atria, interatrial septal thickening, and the classic pattern of restrictive filling on mitral or pulmonary venous Doppler, as well as on tissue Doppler imaging. So Rodney Falk actually described this very early on in 2003 and showed that changes in myocardial strain imaging are earlier markers of amyloid infiltration compared to ejection fraction. This pattern now of what is felt to be apical sparing of global longitudinal strain, where the apical segments of the left ventricle contract very strongly compared to the mid and basal segments. This pattern, called cherry on top on GLS for global longitudinal strain, has been described to be specific for amyloidosis. However, in this study, you'll notice that the investigators compared the apical to basal ratio of global longitudinal strain in control subjects compared to cardiac amyloidosis, hypertensive heart disease, Fabry's disease, and Friedreich's ataxia, and showed that a ratio of more than 2 was most often found in patients with cardiac amyloidosis and much less often found in other pathologies. However, what we are realizing now is if our goal is to identify amyloidosis at an early stage, this marker may not be sufficient to diagnose amyloidosis at an early stage. What about MRI? MRI, because of its tissue characterization properties, is much superior to echocardiography and can more accurately distinguish hypertrophic heart diseases from amyloidosis. In fact, there are certain gadolinium kinetics changes on MR images that are highly suggestive that this particular patient has cardiac amyloidosis. However, the challenge with MRI is that it cannot distinguish AL from ATTR amyloidosis. So the typical structural features seen on echo can be seen. Late gadolinium enhancement, which is either diffuse, focal, transmural, and atrial delayed enhancement are all features seen in cardiac amyloidosis. In addition, earlier detection of disease is possible using MRI, particularly using what is called native T1 imaging. This is pre-contrast myocardial imaging where you're looking at tissue characterization, and then extracellular volume imaging where you compare your pre and post gadolinium contrast images to calculate the extracellular volume. Raymond Kwan from our group looked at ECV in amyloidosis compared to non-amyloid cardiomyopathies and control patients and found that patients with amyloidosis have much higher extracellular volume. The ECV is more than 0.4, whereas in healthy volunteers, it's about 0.25. Again, if our goal is to detect early amyloidosis, then there's a significant overlap in the ECV in this bar here in the non-amyloid cardiomyopathy compared to patients with either clinical or biopsy-proven amyloid. What about radionuclide imaging? So a number of tracers are available. I'll go into some detail about bone-avid compounds. Neuronal imaging agents such as MIBG have been used in the past to identify denervation of the myocardium, particularly in the hereditary form of disease. These are all agents that are now investigational, and we have some experience with fluorobutapir, and I can share some of those data with you. The big difference with radionuclide targeted imaging of amyloid compared to the other structural forms of disease is that targeted molecular imaging can provide a virtual histology image of the entire heart and the whole body. Think of endomyocardial biopsy. We are taking 5 random samples from the right side of the interventricular septum blindly. So it is a challenge to specifically identify amyloid, particularly if you're looking at early disease. Whereas imaging with molecular tracers can provide the whole heart image, and in the AL form of disease, it can actually show you whole body imaging with distribution of amyloid in the entire body, as well as quantitation using advanced techniques. So what about AL amyloidosis? A number of groups, including our own group, have investigated the beta amyloid tracers to image AL and ATTR cardiac amyloidosis. And you can see here C11-PIB, fluorobutapir, C11-PIB, and fluorobutapir, and this is fluorobutaben. All of these studies were pilot studies, used a small number of patients, and showed that this imaging is positive in both AL and ATTR and negative in control patients. Here's an example from one study from our group here. ATTR, short axis of the left ventricle and right ventricle showing intense uptake. AL, intense uptake, both the LV and RV, and this is control showing no uptake. And when we looked at the retention index, you see amyloidosis patients had much higher retention index and 95% confidence intervals, not overlapping the retention in the control subjects. Again, same thing shown in a box and viscous plot. Retention index in controls much lower compared to the patients with ATTR and AL. But the key point on this slide is, look at AL and ATTR. A substantial overlap, again suggesting that although this is an amyloid-specific tracer, does not appear to be specific for AL or ATTR form of disease, but the signal in ATTR is an indication that it may be lower compared to the AL form of disease. So we went ahead and studied this in autoradiography and found very similar results. ATTR amyloidosis, AL here in control, all the blue-green on the section is amyloid on sulfated ash and blue staining. Here's autoradiography with fluorobutapir. Look at the outstanding kind of co-localization. All right. On the top here, the little dark little patches here are actually malignant melanoma deposits with secondaries in the myocardium. And you can see there's no fluorobutapir uptake in those two areas, whereas everywhere else where there's amyloid, you could see the uptake. The control patients showed no uptake, and there was very little non-specific binding of radiotracer. Again, on the slides, we found that the signal from ATTR was somewhat lower compared to the signal from AL. We also looked at whole body imaging with fluorobutapir and found that clinically, involvement of the whole body is challenging. Not many patients really have symptoms of involvement of the parotid or tongue, stomach, or other areas. But on imaging, whether it's visual or quantitative, we were much better positioned to identify early AL amyloid deposits. So here's the image of a healthy control and compared to patients with AL amyloidosis with intense lung uptake. Here are all the other images: tongue, lung, parotids, thyroid, and here's splenic uptake here, and this is stomach. So these are the various images suggesting that as we use FDG in cancer imaging, this may be a new paradigm where we use fluorobutapir to define the extent of AL amyloidosis in the whole body. We also looked at lung AL amyloidosis, and Yuming Kaur, who is a fellow with us, did this work. And what we showed in this particular study is that intense lung uptake is present in some of these patients, but using kinetic parameters as well as target to background ratio, SU max, and retention index, these patients with intense lung uptake have much higher tissue concentration of fluorobutapir. And here's an image showing the same thing. So on top is C11 acetate, which is showing us blood flow to the heart muscle, and here's myocardial perfusion. Okay, and very little lung uptake, but you see patient has pleural effusion, particularly shown on the CT. On the bottom is the fluorobutapir PET on the same patient 2-3 hours later after the C11. So this was 8 a.m. and this was around 2 p.m. Actually more than 2-3 hours, 2 p.m. And what these fluorobutapir images show is intense lung uptake. All right, so this tells us that this lung uptake is not just related to high end-diastolic pressures from the heart failure in these patients, but it's most likely retention, as is shown by the kinetic modeling parameters as well. So what's the advantage of something like this? Think of patients with AL cardiac amyloidosis. They present with shortness of breath. You keep diuresing them, but they don't get better. And you think this is because they have cardiac AL. But the possibility is they may have coexistent lung AL, and they may not be responding to diuresis or treatments because they have pulmonary involvement. So this is, I believe, going to be very, very important moving forward in taking care of some of these patients with challenging symptoms. Sarah Cuddy, one of our fellows, also looked at AL amyloidosis with fluorobutapir, and 45 patients with biopsy-proven systemic AL were included in this study into 3 groups. One was active cardiac amyloidosis, where patients had elevated levels of NT-proBNP and troponin T. This group in the middle was remission. These are patients who had AL amyloidosis who received the full treatment with chemotherapy, and the bone marrow went into remission for at least 1 year. And on the right side is active non-cardiac amyloid. These are patients with active systemic AL amyloidosis with normal cardiac biomarkers, normal wall thickness. So basically, these are the group where you would say no cardiac involvement. But what you noticed in this, interestingly, in this study is half of the patients in this group had retention of floor beta pair similar to patients who had elevated cardiac biomarkers. So these are the patients, for some reason, did not manifest wall thickening, did not manifest biomarker release. Presumably, these are an early stage of AL cardiac amyloidosis. So here's one example, cardiac MRI. Look at the wall thickness being normal, no late gadolinium enhancement. Here's the patient's floor beta pair image showing intense uptake in the septum and in certain other parts of the myocardium. So again, this is one way where targeted molecular imaging can help us identify early disease at a time where the structural manifestations are not apparent and the ECV is not definitively in the amyloidosis range. So what about ATTR cardiac amyloidosis? As I mentioned earlier, this has been, bone avid scintigraphy has been used for ATTR amyloidosis all the way since the early 1980s. Planar imaging was used initially, and soon thereafter, when SPECT became available, most of the literature went with planar and SPECT imaging. So Rodney Fogg also published a paper with PYP in 1983. And as I mentioned earlier, there was a lot of publications. This is number of publications combining amyloidosis, pyrophosphate, or DPD. In the early 80s to early 90s, that decade, there was a lot of activity in this area. Then there was a period of lull. And I believe this was because investigators were scratching their head, not knowing why the results were variable from study to study. And once the recognition was, once it became apparent that these traces were more specific for ATTR, then now you know the field has picked up again and there's a lot more activity in publications. So early studies in small number of patients showed that this test was highly accurate. So DPD imaging picked up ATTR amyloidosis in 100% of the patients, in none of the AL patients, and in none of the control patients. And this is how the scans were interpreted. So planar imaging combined with SPECT imaging. Grade 0 is one where you have no myocardial uptake. Grade 3 is where you have myocardial uptake of tracer greater than rib uptake. All right. So grade 1 is myocardial uptake less than rib uptake, and grade 2 is myocardial uptake equal to rib uptake. Again, it's very, very important to ensure that what you're seeing on planar actually confirms to myocardial uptake on SPECT. And I mention this because we have seen a number of patients referred to our lab for treatment with tafamidis, and one of the most common challenges is that sites are using planar imaging with 1-hour scans and interpreting the scans as positive without looking at the SPECT images, when in fact the uptake on the planar represents blood pool activity and not myocardial activity. So the key point here for all of you is please make sure you look at the SPECT and make sure that the activity on the SPECT looks like myocardial activity and not call blood pool activity as positive. So delayed imaging at 2 to 3 hours is much better than 1-hour imaging to clear the blood pool activity. This is what is recommended by ASNIC currently. It is important to know that some of this bone avid scintigraphy may have low sensitivity in certain hereditary forms of disease. So if your clinical suspicion is high, you might consider proceeding with biopsy. Grade 2 or grade 3 uptake may be seen in patients with light chain amyloidosis. So remember that whenever you use PYP imaging in amyloidosis, in order to avoid a biopsy, you need to exclude AL amyloidosis, and you need to ensure that uptake is in the myocardium. The last point is, at least in the US, technetium-99m labeled MDP is one of the most widely used tracers for bone scanning. And it's important to know that MDP has a low sensitivity for detecting ATTR cardiac amyloidosis. This is important because older patients with prostate cancer or other indications may undergo bone scanning, which may be negative, or patients may then present with heart failure. It's important to know that when the patient has heart failure and you're thinking of ATTR, a negative MDP is insufficient. You need to proceed and repeat the study with either PYP or DTD. So here's the seminal paper that was published in 2016 and included nearly 1,500 patients, nearly 400, 398 with endomyocardial biopsy. So this particular study showed that if you look at a group of patients with grade 2 or grade 3 PYP uptake, and you exclude AL amyloidosis by using a serum free light chain assay, as well as serum and urine immunofixation electrophoresis, then this test was nearly 100% specific for ATTR cardiac amyloidosis. So based on this finding, these investigators concluded that in patients presenting with symptoms of heart failure and typical features of infiltration on echo or MR, a PYP grade 2 or grade 3 uptake after exclusion of AL amyloidosis is nearly 100% specific. Therefore, endomyocardial biopsy can be avoided. This information was actually taken up by the drug manufacturers and patients, and the FDA also allowed inclusion of patients diagnosed by imaging into some of the treatment trials. And of course, now they become candidates for therapy. Look at this end here, where if you consider any grade PYP as positive, grades 1, 2, and 3, and you don't exclude AL amyloidosis, your sensitivity is 89, but your specificity is only 78%. Why is this? This is because 20 to 30% of patients with AL amyloidosis may manifest grade 2 or grade 3 uptake of PYP, DPD, or HNDP. Again, pointing out the importance. Why is this important? Because if you miss AL, that is a medical emergency, right? Untreated AL patients, 50% of them die within 6 months. So very, very important to make sure that you're not missing AL amyloidosis. So tafamidis is the only treatment right now that's FDA approved for ATTR cardiomyopathy. In this seminal study, landmark study, what you see here is patients who received tafamidis, shown in the blue arrow, had much better survival compared to the placebo group shown in red here. But when they looked at the subgroup analysis from this study, what they found was that patients with NYHA classification of heart failure, class 1 or class 2 symptoms, had significant benefit from tafamidis compared to patients with class 3 symptoms. So this led us that patients may be not candidates for treatment. This also raises the other point, which is we now have drugs that improve survival. It's now our responsibility to detect disease at an earlier stage so that the patients can benefit and survive. So the new drugs are really game changers. Tafamidis is effective and improves all-cause mortality and reduced heart failure hospitalization. It's the first targeted therapy for cardiac ATTR amyloidosis. It has the potential to prevent age-related HFpEF if these patients can be identified at an early stage. However, a number of unanswered questions remain. Why would stabilization of TTR improve outcomes? We're not removing the fibril, we're just stabilizing the fibril. How do we deal with the expensive drugs? These drugs are very expensive. How long do we use this treatment for? How do we identify non-responders? So in this particular study, nearly 30% of the patients on tafamidis did not survive beyond 30 months. So again, you go ahead and treat these patients with this expensive therapy, and they don't live beyond 30 months. So again, these are all the areas where there should be ongoing research. To identify response to therapy, we believe that quantitative measures are much more important than relative measures. So a number of investigators have published data on looking at SUV metrics with bone avid scintigraphy. The images here are shown from our lab, looking at visual grade 0, 1, 2, and 3. We looked at a whole body CZT, general purpose CZT scanner with SPECT CT imaging, and showed that SUV max, SUV mean, and total heart cardiac amyloid activity, as well as percent injected dose, increased gradually with visual grade. And this type of quantitation may be what is necessary for us to evaluate response to therapy and to identify non-responders at an early stage. So what about clinical practice guidelines? So this is a slide that I would like to share from my colleague, Dr. Rodney Falk, who runs the amyloidosis program at the Brigham. And so he says one of the major barriers is lack of knowledge about the disease, belief that it is rare, belief that nothing can be done, then concentration on more common diseases such as ischemic heart disease. And the last one I think is very interesting, which is I have never seen amyloidosis, really means I have never diagnosed a patient of mine with amyloidosis. So how do we help practitioners better detect this disease? The societies have all come together. ASNIC led this effort in collaboration with all other imaging societies, as well as the International Society of Amyloidosis, to provide guidance on standardized image acquisition, as well as to provide guidance of appropriate use of imaging in patients with suspected or known amyloidosis. So the experts in this consensus group suggested that amyloidosis can be diagnosed by endomyocardial biopsy or by extracardiac biopsy with typical imaging features on echo or MR for both AL and ATTR. In AL amyloidosis, biopsy proven, if the patient has elevated NT-proBNP or troponin T, that is felt to indicate underlying AL involvement in cardiac amyloidosis. Of course, in ATTR, as we discussed earlier, diagnosis without biopsy is possible using the grade 2, grade 3, excluding AL amyloidosis and looking at typical cardiac imaging features. So who do you test for amyloidosis? Patients who are older, particularly those who are from African American heritage with HFpEF or LV thickening, non-African American patients with HFpEF and LV thickening, low flow, low gradient aortic stenosis, heart failure with unexplained neuropathy, known or suspected hereditary cardiac amyloidosis. And these are the other areas where the experts felt echocardiography may be useful. MGUS or elevated free light chain levels, follow-up of progressive symptoms in patients with known AL or ATTR, and clinical scenarios such as carpal tunnel syndrome, biceps tendon rupture, and lumbar spinal stenosis. These are the clinical manifestations or red flags that may manifest almost 5 to 7 years before involvement of the heart. So if you are faced with patients with these symptoms, consider an echocardiography and close clinical follow-up on these patients. So I just wanted to end with 2 case examples from our institution. Here's an example of a patient with high blood pressure, normal wall thickness in 2011, with increased wall thickness in 2018, 18 millimeters. So the physician looked at the patient's chart and recognized that, yes, he had high blood pressure, but it was well controlled on treatment. So he was really perplexed as to why the ventricle was thickening further. So amyloidosis was considered, and he was referred for a P/P scan. And here's a grade 3 P/P scan confirmed on SPECT CT showing myocardial uptake. The other end of the spectrum is this, where there's a woman who is asymptomatic, but her father died of hereditary ATTR cardiac amyloidosis. She has a gene mutation, the LS60 mutation. Her echo looked normal, but she wanted to be part of one of the drug treatment trials. And as a consequence, we referred her to P/P, and you can see strongly positive P/P in a patient before overt structural changes on echocardiography. So what's the promise of molecular imaging in cardiac amyloidosis? We can potentially avoid the risks and challenges of biopsy. We can define the systemic extent of amyloidosis and hopefully select the best therapy. And if we can refine this strategy, I think what we need for the future is really identify the type of amyloid, develop metrics to identify response to therapy, and really microphenotype disease, because to see change in the whole heart may take a lot of amyloid burden to be removed. But if we can detect microscopic changes or small amount of changes, then we could make treatment decisions based on imaging. So a disease that was once felt to be rare and fatal and only diagnosed by biopsy and treated symptomatically by heart failure management, avoiding digoxin, avoiding beta blockers, avoiding negative inotropic agents, right? That disease can now be diagnosed using imaging non-invasively. Planar and SPECT imaging is used. Once imaging became available, these patients became candidates for treatment trials and new drugs could be developed faster. And these patients, after the approval of these agents, are now candidates for receiving therapy. In my mind, one of the biggest advances that imaging has led to is to really identify screening or to screen patients with HFpEF to identify the underlying prevalence of ATTR cardiac amyloidosis. A large number of studies looking at patients with HFpEF, patients with aortic stenosis, older patients with carpal tunnel syndrome, surgery, a number of clinical scenarios, we now know that 13 to 18% of patients with HFpEF have coexistent underlying TTR amyloidosis, which can be treated. So this could not have been possible if biopsy was the only way to detect disease. Of course, we are looking at a bright future where we can prevent ATTR cardiac amyloidosis by new research and use these agents to avoid onset of ATTR cardiomyopathy. I really think that this storyboard of ATTR cardiac amyloidosis and bone avid scintigraphy is a beautiful story, and that can tell us how we could develop radio tracers for any given disease. And what this story has told us is, if you can identify disease non-invasively and have treatments to treat this disease, I think that radio tracer technique is going to be very, very helpful clinically and is going to change the management paradigm in clinical practice. Thank you very much for your attention.
All right, that's Jean-Luc. Are you coming online? There we go.
I'm coming with you. Sharmila, this is very, very comprehensive. And I really thank you very much. I forgot to mention that you're the current president of the American Society of Nuclear Cardiology. So we have enjoyed our collaboration over the past few years, and I hope you come back and give us an update next year about your great work. We have enjoyed working with you. I'm going to deflect to you the question that I got earlier on, so quick questions. One of the colleagues from Quebec was asking me how many PYP study I do a week. Can you tell us how many studies overall you do, and maybe give us a split between PYP and the other agent that you might be using? How many of these studies do you do per week or per month?
Right. No, that's an excellent question. Really, how many studies you do depends on your clinical setting. So we are a major amyloidosis referral center. So we are seeing patients referred to us. So we not only perform PYP imaging, but we receive scans for second opinion reads from other institutions. At this point, PYP is the only tracer that we're using clinically, and fluorobutapir, the evidence, the little data that I showed you, comes from a research study. It's not approved. So we have no way to order a fluorobutapir study clinically in any of our patients. So how many are we doing? our volumes have gone up. We are doing, I want to say, 5 a week at this point, maybe 1 every day. There's a rare instance where we may do 2 a day, but for the most part, the average looks like 1 every day.
Sharmila, when you do a flow beta peer study on PET scan, you do a total body. As you explained, there are many arguments now to look for deposits not only in the brain, but also elsewhere in the body.
Yes, for the research scans, we did partial body imaging, so 1 bed position on the brain separately, and then we did all the way from the skull base to the kidneys, in addition to cardiac. We do 30 minutes on the heart, and then we do brain, and then the partial body.
I think that there are questions from Stephen Burrell, and I vaguely remember that you know Stephen Burrell. I'm not sure why, but you know Stephen Burrell. So he said, thank you very much for your great lecture. That being said, he said, we have been imaging at 1 hour and 3 hours per guidelines. We know 3 hours is better than 1 hour. Can we dispense the 1 hour imaging and image only at 3 hours?
Yes, hi, Steve. We know Steve very well. He was one of our residents in nuclear medicine, maybe 10 years ago or so. And I know he had started his CYP program at his institution. My answer is yes. The 1 hour is not necessary. 3 hours is adequate, and it is. So my argument is as follows. If your goal is to use the test to avoid a biopsy, we need to maximize the specificity. And clearly the specificity is optimal with delayed imaging, and therefore the 3 hour is the most important image. We are scanning around 2.5 to 3 hours at the Brigham. We've given up on 1 hour a long time ago.
Stephen is always scratching the surface, and he's stating that they have been comparing the heart uptake with rip uptake and not the control level lung. I'm assuming you might have given him a tip of your next publication?
Yes, we also do not do the heart to contralateral ratio at all. We are looking at the visual. We're not looking at a planar ratio, but we're looking at the spec comparing myocardium to rib uptake. So I'm so glad that Steve is following a protocol similar to what we are following.
Well, Sharmila, thank you very much again for taking the time on Saturday afternoon to put such a great academic lecture. I can tell you that we started with about 69% stable attention of the attendees, and we finished with 69, which is a record in the afternoon, still having 69% looking at the lecture. So thank you for keeping up, keeping people on their toes and keeping them awake.
Thank you very much. Really, the honor was mine. Thank you both.
Right on. I'm going to let Andrew know close the day. Andrew, you're muted. I think you're muted.
Sorry, I didn't want to be interrupting the two of you. I say thank you very much, Jean-Luc, and thank you very much, Shamila. A great way to conclude. And that is the conclusion of the first CANM virtual scientific meeting. Certainly, it would be nice to be able to be heading to the hotel lounge now with all the attendees, but I guess we'll have to do that virtually as well. From here, as you see online on the screen, this webinar will be transposed onto the members section of the site. So if you have questions or things you want to fill in afterwards, because it is a lot of information to have thrown at one day, it'll be there for prosperity to look at. As well, very important, I will reiterate a couple of things. This being that the evaluation forms are going to be sent to you. If you don't receive it, send a note to the CANM to make sure you do get it, because we need to get those back in order to give you the CME credits. And equally important for us to get feedback on what today has meant to you and what we can do to continue it and make it better. I thank you all. I enjoyed the day immensely, as I'm sure everybody did. I want to thank all our speakers. I want to thank what I guess you'd call the back house office. Now popping in, here comes Nicola and his colleague Eric, who've done an exceptional job, at least from my standpoint, of keeping us going and very coherent seeming. I also want to thank Helene for a tremendous amount of back office work to make this come together. Without that effort, this would not happen. I want to remind you to keep your eye on the CANM website, because there will be upcoming virtual events over the next number of months. Like I said, the next big one we have planned, that's been alluded to a couple times today, is hopefully a theranostic-based educational session in early spring, when we would normally run our annual meeting. At this point, COVID depending, we are hoping to be able to resurrect the in-person meeting in Halifax end of next September. Fingers crossed, either a vaccine or COVID finally runs away from us, one of the two. At the very least, we will keep the virtual systems going. So I'm closing off. Jean-Luc, thank you. It's been a great day. Nicola, do you have any further comments?
Thank you to the moderators for the great job you've been doing. Thank you for the speakers. Thank you for all attendees. And join us, please, on November 25th for the next webinar from the CANM.
Thanks, everyone. Have a great day.
Thank you, everybody.
Thank
Bye.
you. Bye-bye.
Bye now.
Boom, motherfucker. Boom, motherfucker. Boom, motherfucker.